gastroenterology session, and for that, gastroenterology session, and followed by one talk on nephrology. Now, we have this for the first talk on gastroenterology. We have a speaker, Dr. Sanjeev Pal. He is from Kolkata, and he's working in Rabindranath Tagore Hospital in Kolkata. He will be speak on endoscopic and medical management of obesity. As you all know, it's a pandemic now regarding the obesity. I will hand over it to Dr. Sandeep. Please go on with his talk.
Good afternoon, everyone. Though I stay in Kolkata now, but I am from Assam. I have completed my studies from Dekargaon. So it's indeed a privilege for me to talk in front of my teachers. I can see a lot of my teachers sitting here. So my topic is medical and endoscopic management of obesity. So as you will all agree that obesity is the modern epidemic, or you can say pandemic, because most of the diseases that as a physician we see, like it's linked to the metabolic syndrome, it's linked to obesity, be it diabetes, blood pressure, cholesterol, whatever. So obesity we can define it as a condition that occurs when a person has excess weight or body fat that might affect their health. So we have the definition, like the criteria whom to call obese according to the BMI and the Asian consensus. So the normal BMI is 25 to 29.9 and BMI above 30 we call as obese. But this has changed also, like if we follow the Western standards, the WHO classification classifies obesity as more than 30 BMI, but the Asian consensus of obesity has a different parameter, because for Asians the same thing cannot work. So according to the Asian consensus of obesity, the normal to say obese cutoff is 25. So because there is some discrepancy among this WHO and the Asian consensus, a better way to classify is the waist circumference. So if we take the waist circumference, in females it should be less than 80 centimeter, and in males it should be more than 94 centimeter. Anything above that increases all the metabolic risk factors. So how much weight loss we need to do? So most of the metabolic complications will be taken care by less than 15% weight loss. Even in NAFLD or NASH, around 10% of weight loss will take care of all even the histological improvement will be there if there is only 10% weight loss. So now obesity is a major public health threat. Around 650 million people all over the world are obese. And this is a major problem, and most of the diseases that we treat, the metabolic diseases, be it in cardiology or as a physician, are linked to obesity. Now, life expectancy decreases as BMI increases. If we see the average life expectancy to be 80 years now, if the BMI is more, say 35 to 40, it decreases to 60%, and if the BMI is more, say morbid obesity, the life expectancy also decreases to 50%. So obesity is associated with multiple complications. I will skip this slide. We all know, like depression, asthma, NAFLD, gallstone, CKD, diabetes, everything is associated with obesity. And increased BMI leads to 4 million deaths in 2015, with more than 2/3 from cardiovascular disease. So now coming to the treatment of obesity, if we see the treatment of obesity, the treatment depends on the stage of obesity according to the BMI. So if the BMI is around 25 to 30, there are some certain lifestyle therapies which we will discuss. There are certain medications, and there are a lot of endoscopic methods which are coming to deal with obesity. Though the best strategy is surgery, but again surgery has got a lot of complications, so I will not cover surgery in my topic. I will only discuss about the lifestyle measures and about the medications. So among the lifestyle modification, it should consist of a healthy diet. Needless to mention, we all know this, regular physical exercise. We should ensure good sleep quality and stress mitigation. And the diet should be rich in vegetables, fibers, and caloric restriction is the main. So caloric restriction, to the obesity guidelines, they recommend that the calorie restriction should be around 500 to 750 kilocalorie per day, which can result in a mean loss of around 0.5 to 0.75 kgs per week. Now, for a safe and sustainable weight loss, 0.5 to 1 kg per week, this can be a target, and the caloric target should be around less than 1900 calories for a man and 1400 calories for women. And the best way to achieve this is to swap unhealthy and high energy food choices such as fast food, processed food and sugary drinks. These have to be avoided, including alcohol. Another way is intermittent fasting. There are various studies with alternate day meals, one meal a day diet. There are various regimens we can follow, whatever the patient likes. So this was a study which had compared between normal diet and alternate day fasting. As you can see from the figure here, those patients who had followed this alternate day diet or daily caloric restriction, they have a more weight loss in comparison to the normal cohort. So another strategy is one meal a day. And there is another thought that if diets which are very high in protein, they have some advantage over the diets which are rich in carbohydrates and fat. And the reason why eating a higher percentage of calories from protein may help with weight control is because it induces more satiety and has got a greater thermic effect. So if you see this diagram also, the patients which followed this very low energy diet at a 6-month, they had the highest amount of weight loss when we compared to diet plus exercise or even with drugs. So the best way is to follow a very low energy diet. So again, physical activity comes next after diet. Regular physical activity promotes weight loss by burning calories. It increases the metabolic rate. It builds muscle, which helps in turn to burn more calories. And the typical physical activity that we say is around 45 minutes of brisk walking per day or around 150 to 180 minutes per week. It improves both physical and medical health. Now coming to the topic proper, that is the medications, and next I will discuss the endoscopic methods. So there are few medications which have been approved by FDA also for treatment of obesity. Now when to treat, which patient should be given anti-obesity medicines? So the BMI, the patients who have BMI more than 30 or if the BMI is more than 27 in the presence of one or more comorbidities, this group of patients can be given medications. Now what are the medicines? So the medicines which are there in the market at present available is the phentermine. So I have personally not used this. Orlistat is there, though used to use Orlistat, but Orlistat has got a side effect. It produces oily stools because the mechanism is it inhibits the gastric and the pancreatic lipases. So patients, the acceptability rate is not that good. So this drug, and it causes very modest weight loss, around 3 to 5%. So it is not a very favorable drug. The another drug which we would like to mention, the best drug which is there in this is the liraglutide, and of late the best one is the semaglutide. So this audience will have better knowledge about semaglutide than me. The semaglutide is, the mechanism of action is a GLP-1 agonist, and this can cause a weight loss up to 15%, more than any of the endoscopic procedures can achieve. And it's a very well tolerated drug. The frequent side effects are little bit of GI intolerance. The only problem is costly. So I think with more companies, if they come out with semaglutide, the cost is also going to decrease. So this is the study which compares Orlistat. Orlistat is a pancreatic lipase inhibitor. If you can see, when we compare Orlistat with placebo, this has got a significant loss of weight. So the p-value is significant when it was compared with placebo. Similarly, naltrexone and bupropion is also effective, but again the side effect profile and the acceptability of these drugs is less and not very easily available also. The mechanism of action is this is a norepinephrine and dopamine reuptake inhibitor. So it increases satiety. The other drug is liraglutide. This is a good drug, GLP-1 receptor agonist. This also causes significant weight loss. And the best in the field is about semaglutide. So I would like to mention a little bit about the semaglutide. So semaglutide is a drug which has changed the economy of Denmark. So this drug was made by Novo Nordisk, and this drug is so, it has gained so popularity even in the West that the entire economy of Denmark has changed after discovery of this drug. So this is the semaglutide. If you see, when you compare with placebo, you can see the weight loss is up to 15%, 15 kgs of weight loss it can cause in around 6 months duration. And the mechanism of action is, again, it's a GLP-1 receptor agonist. And there are two other drugs which are in the pipeline. That is, one is setmelanotide and another is tirzepatide. So this tirzepatide is, again, is a very good drug. Though it is in the phase 3 trials now, the mechanism of action, in addition to GLP-1 agonist, this has also GIP agonist. Now GIP works in the hypothalamus and it improves satiety, so the patients don't feel hungry. So again, the side effect profile is also not that bad. It is only GI intolerance, but it's contraindicated patient who has some thyroid malignancy or multiple endocrine neoplasia. It's contraindicated in those patients. So if we see all the drugs that are available, the most effective is tirzepatide, the last one, though it's not yet available, and whatever we have available, semaglutide is the best, followed by tirzepatide. So this is an algorithm. I will skip this. So which medicine to use? Now, if we combine these medications with lifestyle modification, there is additional weight loss of around 10%. Now, coming to the endoscopic interventions, this is very dear to me because I am an endoscopist. So endoscopic bariatric therapies have evolved as an attractive tool for weight loss. So we need to have a middle path like the cardiologists have. They have medicines, then there is CABG. In between, there is PTCA, angioplasty. So similarly, from surgery and medicines, in between, there is something called endoscopic. So among the endoscopic therapies, like there are intragastric balloon, there is gastroplasty techniques, aspiration therapy, and gastrointestinal bypass sleeves. So the intragastric balloon, it's quite a attractive thing. It's not very difficult to do. Indication is BMI more than 35. It can achieve long-term weight loss, but the weight loss is modest. It's not very good. The weight loss is around 15 kilos. Weight loss can be there, and it is anatomy preserving. We are not cutting anything. It's minimally invasive. And nowadays, I will come to my next slide. Nowadays, there are balloons which does not require endoscopy also. The balloon can be swallowed, and it takes its shape inside the body. So the weight loss, as I said, is modest. It is around 10 kilos to 13 kilos. So the balloon which is available in the market is Orbera balloon. It's very easy. I will show you one video which shows like how this balloon is inserted. So this is a cartoon which will show I hope the video works. Yeah. So you can see with an endoscopy, you do an endoscopy and you insert the balloon, and there is a catheter which is attached to the balloon. So it's usually filled up with saline, around 500 ml of normal saline. And after 6 months, you can aspirate the balloon, aspirate all the fluid from the balloon, and can take out the balloon with the help of endoscopy. So it's not a very difficult thing to do. And various multi-center trials has shown its effectivity. I will skip these slides. So these are the various studies which are showed in 140 patients that the weight loss is around 10 to 15%. So there are certain complications very often during the initial days after the placement of the balloon. The patient usually complains of some pain, nausea, some balloon migration can be there, some reflux, and sometimes gastric ulcer due to the pressure effect of the balloon. So next coming to, so this has got a recommendation from the American Gastroenterological Association, strong recommendation to use balloon in case of obesity. This is the Allurion balloon which does not require endoscopy also. The balloon can be swallowed, and when the balloon is swallowed inside, there is usually a catheter attached to the balloon. It's filled with saline, as you can see in number 2. Then after 6 months, around 4 to 5 months, this balloon auto-degenerates inside the stomach with the help of acid, and it is expelled from the body. So endoscopy is also not required for this. So now coming to the topic which is very dear to me, this is endoscopic sleeve gastroplasty. So endoscopic sleeve gastroplasty, nowadays we have stitching device which can be fit in the tip of the endoscope, and you can stitch the stomach from inside. Thereby we reduce the volume of the stomach. So when the volume of the stomach is reduced, the accommodation increases in the fundus. We don't stitch the fundus is left alone, and there is increased satiety and there is decreased gastric emptying. So when there is decreased gastric emptying, weight loss occurs. So I will skip this slide. I will last slide I will show you the video how it works. I have a video of endoscopic sleeve gastroplasty. So these are the various procedures. You can do endoscopic sleeve because there is another procedure called pose. I don't know if I can fast forward the video. So this is how we do endoscopy. So this is inside the stomach. First we mark the stomach around the Getter curvature. So you can mark 2 lines. One, this is usually done in the Getter curvature. So along the anterior wall and along the posterior wall, you can give 2 marks. And along these marks, we can stitch the stomach and decrease the volume of the stomach. So the volume decrease is usually in the body of the stomach. The fundus area is not stitched. So when the fundus area is not stitched, the food stays in the fundus and it's expelled from the stomach very slowly. So the patient has a sense of satiety and the patient doesn't feel hungry. So this is the mechanism how it works. It does not work on any hormones. The simple mechanism is it causes delayed gastric emptying and thereby helps in reduction of the, see, this is the volume of the stomach normal, and after stitching the volume of the stomach decreases. So this is how it works. And what the surgeon does, the surgeon cut, there is another surgery which is called laparoscopic sleeve gastrectomy. So what they do, they cut the stomach along the geta curvature. So the complications associated with those type of surgeries are, there are leaks, there are so many things, but in endoscopic only thing, the leak and all these are not there, easily tolerable, but the effect is also modest. This can cause around 20 kilos of weight loss. Though surgery can cause more weight loss. So this is how it works. So if you see this study, the gastric emptying is increased. So this is the control group and this is the group which has undergone ESG. And so from the baseline, you can see the gastric emptying has increased in this group of patient which has undergone ESG. So similarly, the gastric accommodation in the fundus also increases, whereas the body of the stomach severely gets restricted. So I have discussed all this. And the effect is more if we can combine ESG with one of the GLP-1 analogs. So if we use, this is our Indian data from AIG, which has shown there is even improve in fibrosis, the NFS score, FIB-4 score, everything improves in patients with NASH. So I'll skip these slides. And this can also work, this endoscopic method can also work as a bridge to surgery. Now if you see this patient, this tummy, it's very difficult to do surgery in this type of patients because there is high degree of complications in this group of patients. So you can do an endoscopic procedure, achieve a modest weight loss of around 15 kilos to 20 kilos, then these patients can be subjected to surgery if more weight loss is desired. There is another endoscopic called POSE. I will not go to this. So I'll come to my conclusion slide. There is another procedure called duodenal resurfacing. So in duodenal resurfacing, what we do is with hydrothermic ablation of the duodenal mucosa is done. So when hydrothermic ablation of duodenal mucosa is done, there is insulin resistance improves. This is slated to be the next therapy for diabetes, the endoscopic therapy for diabetes. So if you can improve insulin sensitivity, diabetes also will improve. So this is another endo barrier. We can place a sleeve in the duodenum so that the food does not come in contact with the duodenum. So when the food does not come in contact with the duodenum, there is something called incretin effect, more effect of GLP-1, and the patient's diabetes improves as well as causes weight loss. There can be endoscopic jejuno-ileal diversion with magnet therapy. I'm not going into the details of this. So these are the current available choices. You might accept where you are. You may not want to decrease your weight. You can do weight exercise. You can take help of drugs. You can put an intragastric balloon, or you can go for surgery. Though the effectiveness increases, effective is more if you can do surgery. So my take-home message are, obesity is a chronic, complex, progressive and relapsing disease. Weight loss of more than 10% and maintenance with lifestyle change alone is challenging. You need some more things like endoscopic therapy or surgical therapy or the help of medicine. And the key is to individualize therapies based on patient preference, and the treatment is challenging. One size does not fit all, so we have to individualize. Thank you very much.
Thanks, Sandeep also for nice presentations. Next then you can take a seat.
Dr. Piyush have some announcement, please. Dr. Piyush, go ahead.
Actually, we have one more chairperson with us. We have Dr. Dharam Singh Timung. May I invite him to join on stage? Actually, he is not late. It's we that are early. So I apologize, Dr. Dharam Singh. You're on time. It's us, we are running a bit early.
Yeah,
Please.
now I would like to request Dr. Utpal Jyoti Deka. He is the Assistant Professor, Department of Gastroenterology, Guwahati Medical College. He is very academically active, have published lots of papers. Dr. Utpal. Dr. Utpal, the slide is yours.
Good evening, everybody. Honorable chairpersons, respected teachers, dear colleagues. It is a great privilege for me to speak in front of my teachers, especially in Assam Medical College in Dekargaon. All these big teachers, most of the teachers are here, so I feel very much privileged. So here also I am very much thankful to the organizing committee for giving me this opportunity to speak on refractory ascites management guideline. So 10% of all cirrhotic ascites are refractory to standard medical therapy, and this condition is associated with poor survival of the end stage liver disease complications, and median survival is only 6 months, and with a worsening quality of life. Coming to the definition, how do we define this refractory ascites? According to the criteria of International Ascites Club, refractory ascites is defined as ascites that cannot be mobilized or early recurrence of which cannot be satisfactorily prevented, that is early recurrence after large volume paracentesis by medical therapy. It can be of two types. It may be diuretic resistant ascites, that is lack of response to maximum diuretic, that is intensive diuretic treatment after 400 mg of spironolactone and 160 mg of furosemide with strict dietary sodium restriction, that is less than 88 millimole of sodium or 5.2 gram of our common salt, and it may be diuretic intractables. That's development of some complications, that is diuretic induced, may preclude the use of diuretics. So again, this criteria is revised by the International Ascites Club subsequently. That's now it includes treatment duration on intensive dysdiuretic therapy for at least 1 week and on a strict salt restricted, that it is less than 5.2 gram of common salt. Then lack of response, what do we mean by lack of response? That is mean weight loss of less than 0.8 kg over 4 days period of treatment, and then early ascites recurrence, that is reappearance of ascites within 4 weeks of paracentesis, and then diuretics induced complications, that's development of hepatic encephalopathy, renal impairment, electrolyte imbalance like hyperkalemia, hypokalemia, or severe hyponatremia. Then there are some conditions which mimic refractory ascites termed as pseudo-refractory ascites. Suppose treatment with loop diuretics only with insufficient dose, or it's only one diuretics instead of combinations. Then what we can solve that problem, we should adjust the dose of diuretics. Sometimes over-aggressive from beginning, over-aggressive diuresis with negative fluid balance more than 900 ml per day, then you withhold diuretics for some time, and then impaired renal function caused by iatrogenic factor like use of NSAIDs, AC inhibitors, or nephrotoxic drug in the refractory ascites, or sometimes development of complications because of intractable vomiting, diarrhea, GI bleeding, sepsis, which can cause the impaired renal functions and ultimately mimics refractory ascites. Here you withdraw the noxious agent and treat the underlying condition like control of sepsis, control of fluid management in diarrhea, vomiting. And most important is in case of management of ascites in cirrhotic is uncompliance to sodium restriction. So patient may be, sometimes they believe that the salt, which is common salt, may not cause, they can suppose they sell black salt or other, they think of it is not so containing sodium, but actually, so we should think the appropriate counseling for the patient is very important so that they should be compliant on sodium restriction. Then what are the factors that lead to this refractoriness? Most important factor is the activation of our renin and this angiotensin aldosterone system with autonomic nervous sympathetic nervous system activations and with increased hydrostatic pressures, and this increased renin-angiotensin activation system and sympathetic overactivity of sympathetic nervous system leads to renal vasoconstriction, leading to decreased renal blood flow. And there is also increased proximal tubular reabsorption of sodium, so there is less delivery of sodium after prolonged use of diuretics. There is less delivery of sodium into the distal tubule where the most of the diuretic acts. That also give rise to refractory ascites. Then what are the treatment options available for these conditions? Number one is this terrestrial therapeutic parasynthesis, then TIPS, transplant, some trials with newer therapies, and shunt. I will go one by one. So therapeutic parasynthesis, especially large volume parasynthesis, is the first line of treatment in refractory ascites. It is very effective, old practice, and still it is the first line of treatment, and it can be safely done even with prolonged INR and very low platelets, swing up to less than even 20,000 of platelet. It can be safely done. And if there is no sodium excretion in the urine, then patient may require parasynthesis at interval of 2 weeks. If there is some excretion of sodium, then there may be less frequent parasynthesis requirement. So what do we mean by how we can calculate the dietary compliance? Suppose we remove 10 liter of parasynthetic fluid that contain around 1300 millimole of sodium. If the patient is consuming the prescribed sodium, that is around 88 millimole, or our common salt sodium chloride 5.2 gram, then they can excrete in renal through this one in kidney by 78 millimole per day. So if we remove 10 liter of parasynthetic fluid, ascitic fluid, that can remove the 17 days of retained sodium. So if the patient is requiring parasynthesis at frequent interval, that is at the less than 2 week interval, that means it indicates the patient is not complying with this diuretic therapy, with his sodium restricted diet. So post parasynthesis colloid infusion is always recommendation. So albumin is very effective in preventing especially the PICD, post parasynthesis induced circulatory dysfunction, and it's specially indicated for large volume parasynthesis. At the rate of 8 gram per liter of fluid removed. For less than 5 liter of parasynthesis removed, albumin may not be necessary according to some guideline, but still you can use the alternate plasma expander instead of albumin, which can have the similar efficacy in case of low volume parasynthesis, that is less than 5 liter at a time. But International Ascites Club still recommends synthetic plasma expander for this group, but EASL group, that is European Society for Study of Liver Disease, but they still recommend only albumin in this group, which is more effective, lower liver-related complications. Then why we should use albumin and what dose it is to be given? So these are the evidence. This RCT where they use this 52 patients with parasynthesis with albumin infusion and 53 without albumin infusion. So where they have shown that with albumin infusion there is not much impairment in the renal function or renal activity, but in contrast without albumin infusion there is increase of renin activity and impaired renal functions and electrolyte imbalance, especially hyponatremia. So intravenous albumin infusion is very important during parasynthesis to avoid the renal and electrolyte complications and to avoid the activation of endogenous vasoactive, especially for large volume parasynthesis. This another is where albumin was compared with some alternative plasma expanders like dextrin, polyxylin, where it was shown that albumin is more efficacious in preventing the parasynthesis-induced complications, especially PICD. Then PICD is also associated shorter time to readmission or shorter survival. So here it is shown that in less than 5 liters of tapping, ascitic tapping, there is no difference between albumin infusions or other plasma expander responders, that is dextran or polyxylin, whatever. But if it is tapping is more than 5 liters, there is always favorable outcome with albumin infusion. So is there any contraindications on this parasynthesis, and are there any what are the complications associated with parasynthesis? So complications of parasynthesis, hematoma, you can find abdominal hematoma, we can find up to 1% of patient. It is usually safe, but very rarely it may be life-threatening. And hemoperitoneum or bowel perfusion is a serious complication, but it is very rare, less than 1 per 1000 of the parasynthesis procedures. But contraindication to parasynthesis is clinically evident fibrinolysis or DIC, which we can avoid we should avoid the parasynthesis, but abnormal coagulation profile, which is common with end-stage liver disease, is not a contraindication for parasynthesis. Even patient with prolonged prothrombin time or low platelet count, we can go for parasynthesis. It is not a contraindication, and FFP transfusion is not supported by any data before parasynthesis, even with prolonged prothrombin time. Are these conditions contraindication to the parasynthesis, like renal failure, encephalopathy, thrombocytopenia, low blood pressure, severe jaundice? There are fear of deterioration of these conditions initially. But what this IAC says, International Ascites Club, these are not contraindication for the parasynthesis. You can go over, there is no evidence that this parasynthesis deteriorate these conditions. Then what about the complication is parasynthesis-induced circulatory dysfunction is defined as increase in plasma renin activity of 50% of our baseline up to 4 nanogram per ml on day 6 of post-parasynthesis, which is associated with adverse effect because of renal vasoconstriction by development of hepatorenal syndrome, worsening of hyponatremia, or reappearance of ascites, which ultimately in turn to decrease survival. So albumin infusions, all this it can decrease this parasynthesis into circulatory dysfunction from around 80% to 15%, less than 15%. So to prevent this parasynthesis circulatory dysfunctions, if the therapeutic tapping is more than 5 liters, albumin is always preferred, though these plasma expanders like dextran and polyethylene can reduce the incidence to some extent, but it's not adequate. But in low volume parasynthesis, that is less than 5 liters, there is not much difference between this other plasma expander or even without any use of volume expansion. So the rate of PICD, parasynthesis circulatory dysfunction, almost similar, not much different with albumin. Then another option for us to control this refractory ascites is intrahepatic photosystemic shunt. This is an artificially created shunt radiologically between this portal vein and hepatic veins, which decompress the portal vein, and this reduces the hepatic venous pressure to control the ascites, increase the cardiac output, improve renal functions, or also improve the nutritional status. So, sorry, tips is recommended for the parasynthesis if the frequency is more than 3 times per month, if the parasynthesis is contraindicated, or if it is associated with hepatic hydrothorax, because 20% of refractory ascites is commonly associated with hepatic hydrothorax, which is difficult to be controlled. So there are contraindications if there is pre-existing encephalopathy, advanced liver disease. So TIPS is contraindicated in these conditions. Poor cardiac function, advanced child score, especially if it is more than 10, elderly, and impaired renal and respiratory function. So composite-related mortality with TIPS is 1 to 2%, encephalopathy development of 30 to 50%, shunt occlusion 20%, and there is always risk of infection and hemolysis. So there are many studies comparing the TIPS versus serial large volume parasynthesis. Before 2000, many studies showing that the TIPS was associated with more poor survival, but after 20 to 2000, that many studies showing that ascites control is more with TIPS rather than recurrent parasynthesis, and the survival benefit is also seen with TIPS. So TIPS was always superior to large volume parasynthesis in control of ascites, but at the cost of development of encephalopathy. So to reverse the whole process of postportal hypertension in end-stage liver disease, only solution is liver transplant, which can cure this condition. So, but the problem is that with allocation of liver transplant is based on male score, so patient with ascites may not adequate priority on waiting list in these ascites. So this peritoneal venous shunt earlier done, now it is obsolete almost. This is an alpha pump which transport the ascites fluid from the peritoneal cavity to the bladder through an battery controlled implantable device. So it is under trial, and in US and now in Europe there is a large trial going on. Another newer therapies, what I am doing something on midodrine. So midodrine is an alpha agonist magnetic vasoconstrictor, improve the circulatory volume, improve renal functions, glomerular filtrations, and sodium excretion with better ascites control. So this study, midodrine, though it was originally used as IV agent in Europe and North America, it is from PGI Chandigarh, Birendra Singh. So he just initiated this oral midodrine with this study in 2012, which popularized the use of midodrine, which is now seen to be effective, and also many guidelines, through Indian APASAL guideline, our Asians and European guidelines to recommend midodrine in refractory ascites and in refractory ascites with hepatic hydrothorax. Then what is the use of beta blockers? We should stop the beta blockers in case of refractory ascites. So it has got a poor survival. And so what to conclude?
Time is over.
So to conclude, this is a last slide. So refractory is frequent problem. Therapeutic paracentesis is the first line of treatment. To prevent PICD, albumin and vasopressor are the drug of choice. Tips patient selection is important, but associated with antibiotic encephalopathy. Midodrine is the common way, especially in patients with low mean arterial pressure. Transplant is the way to reverse the process. Thank you.
Thanks, Utpajyoti sir, for nice presentations. Now next topic is management in case of CKD, intra and post dialysis. I request Dr. Karan Saraf to come and give the talk. Yeah, Dr. Karan Saraf, he's a senior nephrologist. He's in XXXII Hospital, Guwahati.
Very warm good evening to you all. At the outset, I thank the scientific committee of APICON Assam for thinking of me to presenting this talk. This is a very vast topic, management of a case of CKD intra and post dialysis, so we need to cover a lot. I have tried to concise and highlight very important points which we all should keep in mind when we are looking into a patient who is undergoing dialysis. I will not go into everything in detail. I'll just give some practical pointers into what should first come to our mind when we deal with a complication. So first and foremost, what are the indications of dialysis in a CKD patient? This is a very gray zone. I think many of us come across patients, for example, you will get an average diabetic patient who develops CKD around about the age of 60. If you happen to see his creatinine is above 5, if you go on and calculate the GFR of the patient, that will come to less than 10. Now, a GFR less than 10 actually qualifies him to be a candidate of maybe requiring dialysis. So the decision of doing a dialysis would depend on these following symptoms. So if the patient is having these kind of uremic symptoms like loss of appetite, nausea, vomiting, itching, hiccups, and so on, you will want to recommend dialysis to these patients. Many a times you will see these patients will be going on taking drugs without doing dialysis even when they develop one of these symptoms, because the creatinine is 6 or 7 and which they think is not very high and which is wrong. So the ideal timing of dialysis is very important. Weight loss and muscle mass loss is an important factor to keep in mind. You will see these patients keep on losing weight, they restrict their protein diet, they become malnourished. Once they lose their muscle mass, the creatinine is going to come down by a bit because the creatinine comes from the muscle, and you will misdiagnose the patient as getting better because the creatinine has improved. In fact, if you see that the patient is catabolic, patient is losing weight above a certain creatinine, that is an indication of dialysis. Once you decide on dialysis, of course, you come to the hemodialysis apparatus. The product water and hemodialysis solution will not go into that. The Achilles heel of dialysis is an access. So you need to have a good access to do dialysis. When I say access, I mean you need a good AV fistula or a central venous catheter to do the dialysis for the patient. What are the RRT options of the patient? You have dialysis, you have transplant, you have peritoneal dialysis. Which one is the best? Undoubtedly, renal transplant is the best out of the lot. The first and foremost recommendation is to be doing a renal transplant. If the patient is not a candidate, and for immediate therapy, you choose either hemodialysis or peritoneal dialysis. The decision between the two depends on logistics. The efficacy of both is the same. In Assam, we tend to migrate more towards hemodialysis because now you have a very widespread national dialysis program providing free dialysis to a lot of patients in all the districts of Assam. So I'll just show what are the some pictorial representations of how you pick up access related problems, because this is the most important thing for a dialysis patient. You have a central venous catheter which is temporary and which is tunneled. On the right side you see it's a temporary catheter that can be kept for about 45 days. On the left side is a tunnel catheter. This tunnel catheter can be retained for 6 months to 1 year. Usually they can be retained for even longer periods if you don't have any infection or thrombosis. So when you initiate dialysis, they should be having one of these catheters. This is a AV fistula. This is a radiocephalic fistula. You can see a very well dilated cephalic vein in the forearm of the patient. The criteria is that this patient should have a more than 600 ml of blood flow per minute. The diameter of the vein should be more than 6 mm, and the depth of the fistula from the skin should be less than 6 mm. How do you assess it? One is clinically, you feel the vein, you will see a very well dilated firm vein in the forearm or in the arm. You do a Doppler scan. In the Doppler scan, the radiologist should be able to tell you that the flow is more than 600. Often you will get a flow of 800, 900, 1000, and the diameter will be around 5.56 mm. So this information is required in the Doppler. If you have a Doppler report which is not mentioning this, that is insufficient. Now, what do you see? When you see a patient on dialysis, you see his arm, and once we see his arm, we see whether the blood flow, when you're putting the patient on dialysis, the dialysis will have a blood pump. The blood pump should have a blood flow of more than 250 ml per minute. Any dialysis done below 250 is inadequate. Look at the skin over the fistula. The skin should not be infected. Look at the hand distal to the fistula. The hand should not be cyanosed. So because AV fistula is a shunt between the artery and the vein, if the shunt is too much, you will have a distal ischemia, which may present as a pain in the fingers, you will have discoloration in the fingers, you will have bluish discoloration of the nails. Look at the arm, whether the arm is swollen or not. If you have a doubt, please say no, the patient should not get a dialysis done through an inadequate fistula. Refer the patient for evaluation of the fistula, because once the fistula is blocked, you don't have any other option. So often first you do a Doppler study. That's the first recommendation you give to a patient who is doing a dialysis through an inadequate fistula. If you identify a stenosis, patient requires a fistuloplasty. If you identify a collateral, the patient has to get the collateral ligated. So this is an example of a fistula which is infected and a fistula which has been double punctured. So when they put the needle in the fistula, if the needle goes through and through, you will have a hematoma formation, and the next dialysis will be a problem. So if the patient comes to you with acute pain in the arm is swollen, the arm is red, give a gap, don't dialyze through the fistula, put a neck catheter, a temporary catheter, give a 15 days gap, antibiotic course, chymotrypsin, painkillers, and then once the arm recovers, we can restart the dialysis through the fistula. This is an AV aneurysm through the fistula, which has formed over the past, say, 1 year, 2 year. If the aneurysm is too big, we cannulate the fistula from a different site. Don't cannulate the AV aneurysm. The skin over the aneurysm has to be examined. If the skin is thin and shiny, that aneurysm can puncture. He has to be referred to the CT waste department for maybe an excision of the aneurysm. Now this is a hand. If you can see the arm, the top picture shows that the hand is cyanosed. This is the Steele syndrome because the fistula is shunting a lot of blood away from the arm. This is a skin allergy reaction because you use antiseptic to clean the skin over the fistula. Sometimes the skin can have an allergic reaction. So you need to change the antiseptic which we are using in the dialysis unit once you see that the patient is allergic to that. Now this is a central vein stenosis. If the arm is swollen, you see collaterals in that arm compared to the other side, please suspect that the patient may be having a central vein stenosis, a brachiocephalic vein or a SVC stenosis. This patient needs to be evaluated further, because once this stenosis is left, it will become chronic and it cannot be treated, it cannot be opened up in the future. So how do you go a step further? You recommend patient DSA or angiography, and you can see on the left side that the SVC is completely blocked. You put a balloon, dilate it, and you can open it up and the arm swelling disappears. Similarly, if the fistula is having a stenosis, on the left side you can see that the cephalic vein is stenosed. You can dilate it and get a good functioning fistula. Now once you are done with the access, we come to what are the common complications which can happen during dialysis. So some of the very common things which the patient will complain is a hypotension which happens during dialysis. Patient can have muscle cramps, nausea, vomiting, headache, chest and back pain, itching. So out of this, nausea and vomiting is basically a symptom which can indicate that the patient is going to have a hypotension during the dialysis. It can also be a precursor to a patient who is going to have a hypoglycemia. So nausea, vomiting is a subjective symptom, may be having multiple underlying causes. Headache generally happens if the patient is having an intradialytic hypertension or the patient has developed an intracranial hemorrhage during the dialysis. Chest and back pain can be a indicator of a MI which is happening during dialysis, or sometimes a dialyzer reaction. Sometimes even sepsis can present as chest and back pain in dialysis. So we go to hypotension. Now the pathophysiology of hypotension is that when we are doing the dialysis and when we are removing ultrafiltration during the dialysis, the blood compartment has to fill up with water from the tissue compartment, and if that refilling is inadequate or not matched to the fluid removal, then you end up having hypotension. That is one of the most common reasons why you have hypotension. The other reasons can be, of course, a cardiac factor. Patient may be having a diastolic dysfunction, arrhythmias, ischemia, which can be precipitated during dialysis. A severely low hemoglobin, less than 8 or 7, can also predispose the patient to hypotension. Occult sepsis, patient who is on central venous catheter, either a tunnel catheter or a non-tunnel catheter, or a patient who is having a fistula skin site infection, can have a sepsis which, a bacteremia which happens during dialysis, and that can present as hypotension. Autonomic neuropathy is very common in diabetic patients. So you can have these patients, at the start the patient's BP will be 170, 180, but as the dialysis goes on, they have a precipitous fall in the BP. And of course, cirrhotic patients have got very low albumin, so the oncotic pressure is very low in the blood compartment, the refilling is compromised, and then you have hypotension. So how you deal with hypotension? So in the acute setting, once the patient has developed hypotension, immediately we need to stop the ultrafiltration. Don't remove any water, put the patient in Trendelenburg position, get the leg up, give some oxygen therapy. If needed, we can give a saline bolus. That should take care of all the hypotension which occurs due to hypovolemia, that is due to fluid removal. But if the patient does not respond to these measures, then probably the patient is having an underlying sepsis or an underlying cardiac event. We need to rule out the three most common things is sepsis, GI bleed, and cardiac event. So check for ECG, any arrhythmias, check for hematocrit, any HB fall, and check for any sepsis by sepsis markers. Now once you are done with the acute setting and the patient is having recurrent hypotension in every dialysis, that is when we need to look at the other factors which are very specific to a CKD patient. These patients, if they take a lot of salt, they will have a lot of water gain in the body. And then between the two dialysis sessions, they can tend to gain a lot of weight. So ideally, we should restrict the interdialytic weight gain to less than 1 kg per day. That means if the patient is dialyzing every 3 days, between two dialysis sessions, the weight should not increase by more than 3 kgs. If the weight increases by more than 3 kgs, you need to remove that much of weight during the next dialysis. And the more the weight you want to remove, the more the water you want to remove, the patient is prone to developing hypotension. So we need to reassess the dry weight. Say sometimes what happens is the patient is removing a lot of water every time. He doesn't know what his target weight is. You remove more than what is required and he becomes hypovolumic. We can do a sodium profiling. So sodium profiling means it is a preset function in the machine. You can just ask the technician to do a sodium profiling. The machine automatically readjusts the sodium in the dialysate. The initial part of the dialysis will be having high sodium, and then gradually the sodium is down titrated. We can ask the technician to reduce the temperature of the dialysate, because if the temperature is high, you have a cutaneous vasodilatation, and that can lead to hypotension. Correction of anemia, of course, is very important. We should, if the patient is having recurrent hypotension and the HB is less than 7 or 8, maybe a 1 or 2 units of packed RBCs is good enough to correct that anemia. Avoid eating during dialysis. We can recommend the patient to not eat, because when they are feeding during dialysis, it's very common for patients to eat their food during the dialysis procedure. And during that time, there is a splanchnic vasodilatation, which causes a decrease in the peripheral resistance, and that can cause hypotension. And this effect lasts for about 2 hours. So the patient should be recommended to not eat during and 2 hours prior to dialysis. And if all measures fail, then we can use midodrine for these kind of patients. So midodrine 10 mg given half an hour to 45 minutes before the dialysis session can help the patient in some cases. Also, it has been seen that a 4 to 6 weeks of sertraline course, that is SSRI, sertraline, can also sometimes prevent hypotension, which is happening recurrently if your dry weight is adequate. Muscle cramps, if again this is related to hypotension. If the patient is hypotensive and the patient is having an excessive weight gain, excessive water removal, the patient is prone to developing muscle cramps. So the treatment is you stop the ultrafiltration, give hypertonic saline so that the cramps do come down. As a preventive measure, we can give carnitine, that is levocarnitine, 20 milligram per kgs during the dialysis or in between the dialysis. Sodium profiling is again one thing which can prevent the muscle cramps. Hypomagnesemia and hypocalcemia predispose these patients to nerve excitability. So if the patient is having recurrent muscle cramps, then we need to check for these. Itching is a common complaint. So apart from lubrication, skin dryness, 2 common things which we need to check is LFT, because these patients can develop hepatitis B and C, leading to an altered LFT, leading to itching. So itching may be in fact the first indicator. Always check the LFT and serology. And PTH, because in CKD population you have hyperparathyroidism, and a high PTH can cause itching. Disequilibrium syndrome is a syndrome which happens during the initiation of dialysis. So if you have a very rapid removal of urea in the beginning, then the patient, there is water shift into the brain and there is cerebral edema causing disequilibrium syndrome. So we initiate very slowly. So any patient who is starting dialysis should be recommended a max of 2.5 hours, that is 2.5 hours of dialysis, low blood flow, 150 ml per minute, and next day you increase by little bit. So next day you increase the flow by 50 and the session by 30 minutes, and then the third day you can go on to do a 4-hour session. Now how do you manage the dry weight? You have machines to do that, but usually we do it clinically. So dry weight is a weight in which the patient should not feel fatigue after the dialysis, patient should not have edema, and on the pre-dialysis day he should not have any breathlessness. So you achieve a weight which keeps him euvolumic. So that is the dry weight. So as a routine monitoring, we check the access, we check the volume status, we check if the patient is having any complications. If none of that, you vaccinate the patient and you plan for the future. And what is the future? You recommend transplant for these patients. This is my last slide. So this is our data. We have done about 30 transplants and we have had 2 deaths, 2 rejections, 27 surviving grafts, and we have a long way to go. Thank you.
Thank you, all the speakers, and excellent talks. Now question is open for the audience.
Excellent talk by all the speakers. But I do have a question to Dr. Sanjay Paul. We know the obesity is a menace of the present day civilization, with no signs of slowing down in the last couple of decades. And what you know from our experience, and there is not a single evidence-based, durable, and efficient therapy to treat obesity, excepting, of course, the bariatric surgery. I have read a recent report in 2021 Lancet. It's out of 174,000 who underwent bariatric surgery. And it was detected, it was shown that there is reduction of all-cause mortality in 50% in the people who are obese with type 2 diabetes. and 30% in people who are obese but not having any sort of diabetes. Now, what do you think? I mean, even the bariatric surgery has got multiple limitations. One of the most important limitation is that it is indicated beyond 35 kg per meter square. So how do you select the patient for EVT, especially in Indian subcontinent? Secondly, do you think that in future, all the endobariatric techniques or therapy can take over the bariatric surgery? Because there is one massive difference between the secretion of GLP in both EVT and bariatric surgery. And that is why one of the slides you have shown, that you need to cover up with GLP-1 analogs when you do the ESG, endoscopic gastrectomy.
Yes.
What is your comment?
Yes, excellent questions and excellent observation. So the panacea is bariatric surgery for morbid obesity, because morbid obesity, only thing that decreases the weight massively is bariatric surgery. But what we have seen from various papers, and that bariatric surgery comes with a lot of complications. So what I have seen, if you do a gastric bypass, mini gastric bypass, or even the laparoscopic gastric sleeve gastrectomy, so all these patients, more often we see there are leaks and all. Now, to see the benefits of, like, if we want to reduce, say, NASH or diabetes, we need a modest weight loss. We don't require that the patient needs to lose 50 kilos of weight. So if we have to gain some metabolic control, even 10 to 15% of weight loss is sufficient. So for this group of patients, suppose the BMI is from 30 to 35. So this group of patients we select for endoscopic bariatric therapy. Plus we can combine with GLP-1 analogs. But those patients who are morbidly obese, say more than 40 BMI, they won't respond to these therapies, endoscopic bariatric therapy. But in this group of patients also, because these patients are very high risk for surgery, we can do a endoscopic bariatric therapy as a bridge therapy, so that the patient reduces, say, around 20 kilos of weight, then he becomes a better candidate for such a morbid surgery. And with the recent studies, as I have shown, like semaglutide, this is a very good, this drug has come, like, at least what the present studies have shown, this causes around 20% of weight loss, total weight loss. And that the last drug which is coming, tirzepatide, so tirzepatide has got a dual mode of action in addition to GLP-1 analog, GIP, it works on the hypothalamus also, thereby decreasing weight. So this drug is also again very good. So if we can combine endoscopic therapy with GLP analogs, we can achieve around 40% weight loss, 40% of the total body weight loss, where the complications would be much less.
Thank you. Because some of the studies you have seen that EBT can raise GLP. And otherwise, some studies as well, EDP lowers the GLP-1. So how do you do that? I mean, if you advise the patient to combine endoscopic procedure or whatever, especially more preferably, of course, the endoscopic sleeve gastrectomy with GLP-1 analogs.
So this EBTs, endoscopic bariatric therapies, they don't have much effect on the hormones. The hormones are decreased by surgery. So if we do a laparoscopic sleeve gastrectomy, the hormone which is decreased is ghrelin, because ghrelin is an orexigenic hormone. So if there is more ghrelin in the body, we feel more hunger. So endoscopic bariatric therapies, they don't have much effect on the hormones. So endoscopic bariatric therapy, they work by delaying the gastric emptying. Because what happens, we don't stitch up the fundus. The fundus is left. So the food is there in the fundus for a prolonged period of time. So the patient does not feel hungry. So the gastric emptying is delayed. So that's why the weight loss is also modest. And the weight loss is much better in surgery because of the other hormonal modification also.
Thank you. We'll have a talk of this. Thank you.
Thank you, sir.
Any question? Sir, Sir Utpal, I will ask one question. While giving this midodrel, any role of mean arterial pressure?
Thank you. Very good question. Midodrine, it increases the alpha-adrenergic agonist, so it increases the mean arterial pressure. By increasing the mean arterial pressure, it increases the renal perfusion and ultimately will GFR and increases the, that's called natriuresis. What is our aim to cause natriuresis to control the ascites? So it increases the mean arterial pressure.
One question. Yeah, my question your comment on acute peritoneal dialysis? Does it still have a role? We need to shelve the procedure. Acute peritoneal dialysis.
It depends on what setting we are working in. So in a tertiary hospital, if you have facilities for slow, low efficiency dialysis, that is SLED and CRRT, then the role of acute PD really becomes very limited. But if you are working in a setting where you don't have access to these modalities, then acute PD definitely has a role for patients who are hemodynamically unstable to undergo intermittent hemodialysis. Efficacy wise, acute peritoneal dialysis is effective, it's not ineffective. But the cumbersome of doing an acute PD versus the outcome that you derive by doing it vis-a-vis the SLED and the CRRT shows that maybe CRRT and SLED is much more effective in controlling the time-to-time variations in an acute setting, like the metabolic acidosis, the electrolyte imbalances. So you can tweak those things very acutely in those modalities. But of course, if you don't have access to those modalities, then acute PD is a good option.
Sandipal sir, there is any role of intermediate fasting with the medication GPLP antagonist?
So among the lifestyle measures that we take, so there are various modalities in dietary restriction. There is intermittent fasting, there is 1 meal a diet, there is daily caloric restriction. So all these modalities have been tried. The only thing is this causes very minimal weight loss. So this can only cause around 3 to 5% weight loss, which is not sufficient. So usually we do both, like this should be combined. Dietary restriction plus physical activity plus one of the drugs, if we can give, all taken together, if it can cause even 10 to 15% of weight loss, that can work.
Just one question for you, sir. Is there any role of nitroglycerin NTG in a case of CKD with pulmonary edema? Is there any clinical trials like?
I don't think nitroglycerin has been studied exclusively in CKD patients coming with pulmonary edema. So because these patients who come with pulmonary edema are usually volume overloaded. So, and if they present with accelerated hypertension, then nitroglycerin is used as an agent to bring down that blood pressure, to decrease the afterload for the heart, so that you can tide over that crisis. So basically it's an accelerated hypertension related acute LVF. So we start them on dialysis, get the ultrafiltration out, and control the blood pressure by using nitroglycerin.
I have a simple question to Dr. Poldeka, sir. Sir, what do you think regarding the refractory ascites? What should be both for large volume as well as the low volume paracentesis? What will say interval that we can undergo?
So interval depends upon the reappearance of ascites, that is, and patient's compliance of with the salt. So if it is, suppose if we do a paracentesis of 10 liters at a time in large volume paracentesis, it can remove the sodium of content of body sodium of around 17 to 18 days. That is around 1300 millimole sodium it can remove. So, and the thing is, we can go for up to safely up to 10 liters of this. But the thing is, in large volume paracentesis, we always go with albumin infusion. It is a compulsory must. But in low volume paracentesis, even without albumin infusion, also we can go for it. And interval depends upon the rapidity which there are many factors. It's upon the, suppose the severity of portal hypertension, then patient's compliance with the salt intake, and then also the other complications like diuretic induced complication like azotemia or have electrolyte imbalance. All these factors play a role in the interval of doing the paracentesis individually.
Okay, then we'll wind up the session out here. So thank you to all the speakers and
thank you
for the audience for your kind patient hearing. Thank you.
would like to thank all our three speakers and our respected chairpersons for a highly enlightening session. We have almost come to the end of today's academic program. To wrap up day one of the 32nd APICON Assam 2023, we have a respiratory medicine workshop lined up for you all. To conduct the workshop, I would like to call upon the stage Dr. Jogesh Sharma, Dr. Kripesh Sharma, and Dr. Suresh Sharma. To moderate the session, I would like to call upon the podium Dr. Anuradha Deori ma'am, Dr. Ashwini Bezborua ma'am, and Dr. Pulak Das sir.
Good afternoon to everybody. First of all, I congratulate the team of Tezpur branch because this is a record. Because we are actually time. It is not in time also, but before time. Probably it is happening in the first time in Assam, not only in Assam, even in the national conference also. So I salute the team for that first. Second, I am moderator at the same time. If I get time, I will present few cases because this is an workshop, two workshops. One is on NIV and another is on spirometry. But thing is that it is not possible to cover within 1 hour. But since today everything is within time, rather before time, we will also try. But if we get time, lastly we will present few cases so that at least we can clear 80%, especially for the postgraduate and DNB student, spirometry. With this, I first request to Kripesh Sharma to start this talk.
Good evening, everyone. First of all, I would like to thank the organizer for inviting me for Assam APICON 2023 in Tezpur. So, over next around 20 minutes, I am going to speak on non-invasive ventilation. So, it will be on two parts where I will first going to the basic principles and then followed by the clinical application. If we go by the history, this was where this Paracelsus in 1530 and Vesalius in 1514, they have shown the concept of mechanical ventilation, and then Vesalius shown the tracheostomy and mechanical ventilation in an animal model. Then later on in 17th centuries, we can see that mouth-to-mouth breathing and then a device to give resuscitation has been evolved. Then in 1864, the negative lung ventilation has been developed. These are called iron lung, which were become very important during polio epidemic. So negative pressure ventilation using cruise respirator or iron lung machine was prevailing in the first part of 20th century. And during polio epidemics in Copenhagen in 1952, positive pressure ventilation via tracheostomy has evolved, and they have shown that by giving positive pressure ventilation, mortality has been reduced from 92 to 25%. Then in 1981, first the CPAP, that is a continuous positive air pressure simple device, has been developed to treat basically sleep apnea. And in 83 onwards, the development of non-invasive ventilation, that is we call NIV or BiPAP, has been evolved. It was first tried in a patient of a neuromuscular disease who developed chronic respiratory failure. So what is non-invasive ventilator or NIV? So non-invasive ventilation is the delivery of ventilatory support without the need of an invasive artificial airway. So why there is an interest between the NIV? Because they have certain advantage over invasive mechanical ventilation. So they can prevent complication related to the process of intubation and mechanical ventilation. Like there will be less risk of aspiration, airway trauma, or cardiac arrhythmias or hypotension that can occur during the positive pressure ventilation, or excessive positive pressure ventilation can cause damage to the lung through barotrauma. So these complications can be minimized with NIV. Secondly, complication caused by loss of airway defense mechanism. So when there is a endotracheal intubation tube is there, the airway defense mechanism is reduced, so there is a more risk of lower secondary bacterial infection or hospital-acquired pneumonia, so that can be minimized by NIV. Then complication that can occur after removal of endotracheal tube, like post-extubation complication like hoarseness or stenosis of the upper airway, hemoptysis, all these things can be minimized. And then lastly, this NIV is comfortable because the patient, we can buy NIV, we can reduce the discomfort due to invasive ventilation, and also patient can eat and communicate, so patient doesn't need to be sedated on NIV. So like invasive ventilation, non-invasive ventilation has certain mode, but we can provide NIV through pressure control mode or volume control mode. So pressure is a targeted pressure, airway pressure will be delivered, and volume we can adjust the targeted amount of tidal volume to the airway. Then it can be assisted where patient will also breathe, and some extent some of the breath will be given by the machine, and a mandatory where the ventilator will completely control the respiration. But in practical use, most of the NIVs are basically pressure control and assisted mode only. So before knowing about the this ventilatory support, we should know how the respiratory failure occur basically. So this is a respiratory pump where is begin with a respiratory center in the brainstem, where it sends signal through the motor neuron to the neuromuscular junction, and then it causes respiratory muscle, inspiratory muscle to contract. This contraction of the inspiratory muscle basically will cause expansion of the rib cage, and this will cause a reduce in the negative pleural pressure, and alveolar pressure will fall, and patient air will flow into the lungs. So this is the beginning of inspiration. So any part of this respiratory pump pathway where there is a defect, it can cause respiratory failure. So like anything that can depress the central nervous system, or anything that can like sedation or any central nervous system causes, then any diseases that can affect the neuromuscular peripheral nerves, etc., like ALS, myasthenia gravis, or any myopathies, can affect the this neuromuscular pathway. Then mechanical disturbance like hyperinflation in COPD, or rib cage deformity like severe kyphocoliosis can affect the rib cage and the respiratory muscle capacity. Then thoracic instability may be following the any road traffic accident. Then reduced compliance, because if the anything between the pleura like pneumothorax, pleural effusion can cause reduced compliance of the lung. And then increased airway resistance. This may be because of the airway, in case of asthma patient, where airway resistance will be increased. So in all these cases, patient may develop respiratory failure, and where we can apply NIV. Apart from the respiratory pump, we have the lung parenchyma as well. So whenever there is a respiratory pump is failed, then usually patient will have hypercapnic respiratory failure. The carbon dioxide will reduce. But in case of, carbon dioxide will increase and oxygen will reduce. But if the lung parenchyma is primarily involved, then the respiratory failure is usually hypoxic respiratory failure. So how NIV basically help to reduce or overcome the respiratory failure? So they basically do two parts. They will reduce the work of breathing and they will improve the gas exchange. So how the work of breathing will be reduced? By increasing transpulmonary pressure. So whenever we apply a positive airway pressure through invasive or non-invasive ventilation, they will increase the transpulmonary pressure, they will inflate the lung, they will increase the tidal volume, they will reduce the inspiratory muscle workload. So all this mechanism, they will reduce the work of breathing. Secondly, they will improve the gas exchange by increasing the alveolar ventilation, they will increase the functional residual capacity, and they will reduce the shunt, so that oxygenation of the blood will be better. So here we can see a schematic diagram. So patient, suppose with a bronchial asthma patient, they will develop bronchospasm, they will have increased, or patient will have increased mucosal secretion, airway infection. They will cause basically two things. They will increase the airway resistance and it will increase the work of breathing. Then patient will also have a air trapping, because the hyperinflated lung cannot completely exhale the air that they inhale. So this air trapping will cause three basic problems. One is the diaphragm will be flattened because of the hyperinflation, elastic recoil of the lung will increase, and there is a positive inspiratory pressure. So all these things will basically again lead to muscle weakness, respiratory muscle weakness, and increased work of breathing, and then ultimately they will cause respiratory muscle failure and decreased tidal volume and increased carbon dioxide level. So in non-invasive ventilation, we have basically two support systems with the inspiratory support, that is called IPUP, inspiratory positive airway pressure, and CPUP or P, positive inspiratory pressure, or expiratory EPUP. So this IPUP will help to improve the tidal volume, and the CPUP will improve the dyspnea and reduce work of breathing. And by targeting these two portion of the respiratory failure, basically the NIV works. So NIV also increases the transthoracic pressure. This increase in the transthoracic pressure will cause a decrease in the pre and afterload, and plus transmyocardial pressure will also affect it. So this will also improve the cardiac output. So to start a NIV, we need a teamwork, because like an invasive ventilation, we put a patient on an invasive ventilation and then we can relax, but NIV need a constant monitoring of the patient. We need a team of doctor, nurse, and the respiratory therapist, so that they know what to do and how to monitor the patient. So we have to be sure about what will be the goal of NIV treatment when we apply to the patient, what group of patient will be respond, and we have to exclude contraindication. So there are certain goals. The goal of NIV is to prevent or occurrence of impeding acute respiratory failure or post-extubation failure, where respiratory failure has not been established but is likely to go into respiratory failure. Secondly, to prevent further clinical or physiological deterioration where patient has already developed a respiratory failure but is early part of the disease. Or NIV may help as an alternative to invasive ventilation in a very advanced stage of disease where invasive ventilation required, but again prognosis is very poor. Or as a part of a do not intubate or do not resuscitate patient also. Then certain predictors are there that will predict that this group of patient will benefit from NIV or not. So there are certain predictor of NIV failure. So if these factors are there, then this it indicates that the patient is most likely to fail NIV and they may go into invasive ventilation. So these failures are like in case of a hypercapnic respiratory failure, like before NIV, if the patient has low BMI, they have a poor general health, pneumonia, excessive secretion, they have a high severity score index, respiratory rate is more than 30, and during NIV, if they show no improvement within 2 hours, they have then all these parameters can indicate a poor outcome. Then in case of a hypoxemic respiratory failure, like a patient have severe disease with ARDS or pneumonia, elderly age, then the risk of NIV failure is high. So the take-home message is NIV has a certain advantage over invasive ventilation. NIV plays an important role in treating acute and chronic respiratory failure, but it requires teamwork with proper patient selection and proper monitoring. Thank you. Then I will next I'm going to the next presentation with the practical application of NIVs. So because of the short time, I'm moving little fast. So how to initiate NIV? What are the troubleshooting of NIV? These are the two particular points I'm going to focus. So we have to focus on patient most likely to be benefit from non-invasive ventilation. So this group of patients are patients at the risk of endotracheal intubation. So these are patients, suppose a COPD patient with a type 2 respiratory failure who has PCO2 between is increasing, pH is between 7.25 to 7.35 conscious oriented. So these are the group patients who may require intubation, but still they are stable. So this group of patients may benefit from NIV, and we can prevent intubation. Then moderate to severe dyspnea, respiratory rate patient with 30 to 50, patient having accessory muscle use, patient with respiratory failure who has PO2 FA2 ratio less than 200 while on venturi marks, or patient less than 300 but increasing risk of complication because of underlying background disease like hematological malignancy or post-operative patient. Then early in the evolution of acute respiratory failure, then if the underlying disease are likely to respond within few days where NIV may be more useful. Then apart from this, we must know that which group of patient may not benefit from NIV or there are certain contraindications. So if the patient has emergent respiratory failure, acute respiratory failure who are on CPR or respiratory arrest, then patient has a very severe illness score, so they may not respond to NIV. Then if the patient is not cooperative, or patient is having encephalopathy, if the patient has unstable cardiac condition like arrhythmias or ischemias, and if the patient has upper airway problems like GI bleeding, vomiting, or if the patient has maxillofacial or upper airway surgeries recently done, or patient has untreated pneumothorax, or if the patient has excessive secretion which can likely to aspirate, or patient cannot protect their airways. So these are the group of patients where we should not apply the NIV. So how we should initiate non-invasive ventilation? So first of all, we have to decide on management plan and inform the ICU, because any patient we put on NIV may improve or may not. If they may not improve, they may require invasive ventilation. Then we have to explain the procedure to the patient, because majority of the patient will be conscious oriented. We have to select a proper mask to fit the patient, because the machine and the interface through which we connect the patient with the machine all are important. So we have to select the proper mask that can fit the patient and that can adequately deliver without much leakage. Then we have to ask the patient to hold the mask and hold by themselves so they get familiarized. Then we have to set up the NIV. We have to set up certain parameters which I will explain. Then we have to start NIV, allowing the patient to hold the mask to the face for first few minutes. Then we have to fix the mask. We have to minimize the leak, and we have to use the oximeter to gauge response. Then we have to remind patient not to eat or drink when the patient is on NIV, or even after taking some food orally. Patient should not use NIV at least for 1 hour. Then we have to instruct the patient how to summon for help if the patient finds some discomfort on NIV. Then we have to make any adjustment to the mask or setting according to the parameter on follow-up. We have to do arterial blood gas analysis at least after 1 hour after initial starting of NIV. Then after the patient is responding, we have to adjust the oxygenation. We have to adjust the setting of the NIV according to the patient's clinical and arterial blood gas parameters. And if the patient is not responding and worsening, then we should not wait and continue in NIV. We have to proceed for invasive ventilation. So protocol is to maintain the patient on non-invasive ventilation in initial first 24 hours as much as possible. Then we have to progressively discontinue use after clinical improvement. And exact timing depends upon patient's tolerance and clinical condition. So there are several modes of NIV that we can use. So patient, there may be volume, pressure, or hybrid mode, and then spontaneous time or spontaneous time modes are there. Then there are different interface through which we can apply NIV, like face masks or nasal masks or full masks. Then there are certain basic parameter basically we need to set during the NIV. These are all inspiratory positive airway pressure, expiratory positive airway pressure, inspiratory time, rise time, trigger, and REM. These are the basic parameter we need to adjust in most of the NIV according to the then usually the patient should be on NIV should be in a propped up or sitting. Then ideal interference and ventilator I'm not going to speak. So majority time there are either volume or pressure targeted mode can be applied on NIV, but majority time this volume targeted ventilators are not good in leak compensation. So majority time we use this pressure targeted mode on NIV. So basically these are the two most important parameters when we put the patient on NIV. Either one is our expiratory positive airway pressure and is our inspiratory positive airway pressure. The difference between two pressure support during the inspiration and expiration is basically the pressure support, which will help to ventilate the lung and which will help to remove the carbon dioxide. So EPUB or expiratory positive airway pressure is critical for maintaining an expiratory flow through the mask, tubing, and expiratory valve that will help to wash the carbon dioxide and avoid rebreathing. And EPUB increases the functional residual capacity and also it improves the ventilation perfusion mismatch. Then EPUB also acts as a pneumatic spline, keep the upper airway stable if the patient has underlying upper airway problems. Then EPUB also counteract the effect of intrinsic PEEP. This intrinsic PEEP is basically what happens in patient of a COPD. If they inhale, the air enters into the lung, but they cannot completely exhale the air from the lung. So with each successive breathing, the air get trapped inside the lung, and this will cause a pressure inside the lung, which we call intrinsic PEEP. So EPUB, when you put a EPUB pressure, that will help to counteract the intrinsic PEEP and help to exhale the air from the lung adequately. Then EPUB setting is require a gradual titration. So usually EPUB we keep at a constant pressure of 5 or 6, and then EPUB we adjust according to the patient's arterial blood gas and carbon dioxide levels. So EPUB pressure support actually basically provides support to the respiratory muscle and it corrects the alveolar hypoventilation. So this difference between the EPUB and EPUB is the pressure support, and it is proportional to the tidal volume. So if we feel that patient carbon dioxide is increasing, then we need to increase the tidal volume, and to increase the tidal volume we have to increase the EPUB pressure. Then the level of pressure support, particularly in COPD patient, we have to keep in a higher level compared to the other type of respiratory failure. Then there are spontaneous, there are different modes like spontaneous time or time modes are there. So in spontaneous mode, ventilator will pressurize or will give the pressure support only when the patient will give a inspiratory effort. Spontaneous time, there is a spontaneous of it will deliver the support, and also there will be particular time set. At that time also ventilator will deliver support. Time mode is basically for patient with do not resuscitate or do not intubation group of patients. Then rise time is another parameter we need to set. So rise time is an important parameter for work of breathing and patient comfort. So usually it has to be kept between 100 to 350 milliseconds. So rise time should be as short as possible in case of obstructive airway disease, and it will be on a higher side in case of a restrictive disorder. So if the rise time is kept low, it will give more time for expiration, lesser time for inspiration, and vice versa. So this is the rise concept of rise time. So this is the rise time, and this is the EPUB pressure, that is the expiratory pressure, and this is the inspiratory pressure. So if we keep rise time lower, then the patient will go early into the inspiration, and then it will go quickly into the expiration, so more time will be given for expiration. Then there is another two parameters we may get in some non-invasive ventilator is called inspiratory and expiratory duration of pressurization. So this is called T min and T max. That is the T min is the minimum time that is will be given for inspiration, and Ti max is the maximum time will be given for expiration. So this Ti min should be higher than the rise time, so that patient can get adequate respiratory support. So here we can see this is a patient where we get this is the rise time, and this is the T min, and this is the T max. So during this period, their ventilator will trigger from inspiration to expiration. So this parameters has to be kept on a lower side in case of a type COPD patient, and it will be on a higher side for a restrictive disorder patient. Then another parameter that we have to set is the inspiratory trigger. Mostly it is a trigger is a flow dependent, and we have to set according to the standard parameter as per the default setting of the ventilator. Then cycling is basically the change from inspiration to expiration. So this is important to have adequate patient ventilator synchrony for prevention of dynamic hyperinflation of the lung, and for patient comfort and for efficacy of the NIV support. So cycling is recommended to adjust the cycling criteria to the high percentage for peak inspiratory flow in obstructive disorder and to low percentage for a restrictive disorder. So this is how we set how our graph for a obstructive airway disease. So here we have kept rise time at a lower part, and then Ti max and min on a lower part, so patient will have a lesser time on inspiration and more time on expiration, and cycling has been kept on a higher part of the flow, so this will cycle quickly from inspiration to expiration. Now coming to a restrictive disorder, here we can see that we have kept T max on a maximum time and cycling on the lower part of the inspiratory flow, so there will be more time, so equal time on inspiration and expiration. So this is for a restrictive disorder. Then finally coming to the troubleshooting. So how does one detect that NIV is not going well, or there is some problem has occurred during NIV? The history is always important. If the patient is not comfortable, using a systematic checklist we can use like that of a ventilator associated symptom, we can make out that the NIV is not working. Is important and may help to identify the specific type of complication of NIV. Then monitoring like your oxygen monitoring, SpO2 monitoring, or timely arterial blood gas analysis, or ventilator graphics or software can also help us to make out the troubleshooting problem. Then if the patient is after adjusting all the setting is not improving, then and patient is having residual hypoventilation, then this group of patient may need transcutaneous capnography or respiratory polygraphy or sleep study under NIV. Then what are the troubleshooting or problem that we may encounter during NIV? So these are the problem that we may encounter, like leak. If the leak is more, the pressurization of the airway may not be adequate, patient may not have adequate oxygenation and removal of carbon dioxide. Then patient ventilator asynchrony is again important troubleshooting. If this asynchrony is there, then patient, it will cause more discomfort to the patient, and patient may refuse to use the NIV. Then there may be persistent hypercapnia or hypoxia. If there is a hypercapnia, we have to increase the inspiratory support, and if there is hypoxia, we have to look for the underlying cause, if any. Then patient may have underlying drop in oxygen saturation and increase in nocturnal percutaneous carbon dioxide. This indicates that patient has underlying sleep disorder breathing that we have to address, where again we may need to give high EPUB support to support the upper airways. Then there may be low compliance and patient discomfort, so sometimes counseling or giving a small amount of sedation may be helpful. Then patient may develop dynamic hypermesis or intrinsic PEEP, which can be overcome by increasing the EPA pressure. Then patient may have developed respiratory distress while interrupting NIV. This indicates a severe respiratory muscle weakness. In that case, patient may require a prolonged NIV or a home NIV. So with this, I conclude my presentation. Thank you. Question?
So discussion will be wrapped.
Good evening, everyone. Thank you, the organizers of the APICON 2023, for giving us the opportunity for this workshop on NIV as well as on the spirometry in clinical practice. So spirometry is one of the tests among the pulmonary function tests, which is used to assess the lung function for various reasons to quantify the type of disorder. And it's basically mainly based on the principle of change in lung volume with forced respiratory maneuvers. So though it's not a costly test, but it's not commonly utilized. And there's various factors relating to it. Machine, because unlike other tests which are predominantly machine oriented, here the reporting from machine is not good enough and it's not reliable. It's effort dependent. That means the patient effort is very much important. If the patient is not performing spirometry well, then we may get a false or erroneous result. A skilled technician is usually required, which is very difficult to get in our setup. And lastly, most of the physicians may not be trained well enough to interpret a spirometry, and they mainly rely on the report which is given by the machine, which most of the time is not correct. We can skip this one, constant of time. So just one slide I will tell in the interpretation how to interpret. Before that, so all the machines which are available, mostly commercial, they are basically based on the data which are from the Western population, and the lung function volume, like another parameter, other parameters also of Indian population may not be same as that is from the Western population. So we have our own data now, and it's a study done by Sunil Sabra sir and his colleague. And now we have our own validated data for interpretation of spirometry in Indian population. So there are two types of spirometer, volume displacement and flow type. Both are reliable and both give reproducible result if they are performed accurately and with the criteria which is given by the ATS ERS. So first coming on to the indication. So it can be used for both diagnosis as well as for monitoring various respiratory disorder. So for diagnostic purpose, we commonly use it for any patient who presented with breathing difficulty or chronic cough. Very helpful in the diagnosis of obstructive airway disease. In fact, spirometry is one of the most important criteria to diagnose a case of COPD. It can also be used in screening of individuals having pulmonary disease or assessment of preoperative risk. Now, which preoperative risk we can discuss later on, because most of the common call which we get from medicine or respiratory medicine from surgery department is fitness for surgery. If the patient is having some findings on the chest X-ray, a spirometry is performed, and they ask whether the patient is fit for surgery or not. And lastly, assessment of health status before beginning strenuous physical activity. And in case of monitoring, we commonly use for prognosis of certain disease while they are on treatment, mainly interstitial lung disease or COPD. Then people exposed to injurious agents. Mostly people who are working in coal mine industry or exposed to certain chemicals which may have known to cause occupational lung disease such as pneumoconiosis. So spirometry may be a very important tool in monitoring those patients. And lastly, adverse drug reaction to certain drugs which may cause lung fibrosis or any other lung complication. So test preparation. So firstly, definitely the equipment has to be calibrated and measures should be taken care of so that there should not be any confounding factor which may cause lung inflammation or may cause hamper in the expansion of the lung, which may include any tight clothing. If the patient is wearing any dental dentures or if it is loose, he should be asked to remove it because chances of aspiration may be there. Ideally, the test should be done in a sitting position because if the patient is standing and going for a strenuous or forceful expiratory maneuver, he may experience a syncope and may fall down. The height and weight and age of the patient is recorded, and the patient should be told properly how to perform a test, because every chance is there he will be doing this test for the first time, and it's all related to the effort of the patient. If the patient is performing the test to his best effort, definitely the test will be reproducible the multiple times if we are doing that test. So there are certain prerequisites. So smoking patient should not have smoked within 1 hour, because smoking is known to cause some degree of airway inflammation, which may hamper with the values of the FEV1 or FVC. Alcohol consumption at least 4 hours before should be discouraged. Patient should not have performed vigorous exercise, because if the patient has performed vigorous exercise, he may have gone into respiratory fatigue, and we may get an erroneous low value of FEV1 or FVC, and this curve may appear as a restrictive spirometry. Patient should not be wearing any tight clothes, because this may hamper with the expansion of the chest, and a heavy meal should also be avoided in the last 2 hours for the same reason. So the technique which we have a machine we'll show later on once I complete this one. So the patient is asked to breathe as deep as possible, and a nose clip is applied. Mouthpiece is put in his mouth, clenched with the teeth, and the lips are tightly sealing the mouthpiece. The patient, after inhaling as deep as possible, then exhale as fast, as rapidly, and as prolonged as possible, at least for 6 seconds. After complete exhalation, again the patient will take deep breath, and this will complete one cycle of the spirometry. And now this should be repeated for minimum of 3 times, because to come to a conclusion we require at least 3 acceptable curves, and this acceptability criteria are from the ATS-ERS, the American Thoracic Society, as well as the European Respiratory Society, and then the highest value from this thing are taken out. There are certain contraindications. There is no absolute contraindication, but relative contraindications are there. So anything which causes sudden change in transthoracic pressure, which may aggravate certain condition. So in those cases, we should be very cautious, or preferably be avoiding this thing. So mainly if the patient is having nausea, vomiting, if hemoptysis is present, because a sudden coughing out may precipitate an episode of hemoptysis, pneumothorax may be aggravated. Recent abdominal or thoracic surgery may increase the transthoracic or transabdominal pressure and may cause pain at the site. Ocular surgery, recent MI and thoracic aneurysm there are case reports of rupture of thoracic aneurysm after performing a vigorous spirometry. So what are the maximum number of maneuvers we can do, because since it's effort dependent and we have to look out for an acceptable curve, and at least 3 acceptable curves should be required. So minimum 3 and maximum up to 8 a patient can go. But patient can go beyond 8 also, but every chances are there after 8 maneuvers he will go into fatigue, and this test will not be reproducible. So when we say that the end of test criteria is met, when the patient is experiencing discomfort, or if the curve is satisfactory enough and there is no change in volume for the last 1 second, or the change in volume is less than 25 ml. Time exhale for at least 3 seconds in children and up to 6 seconds in adult in a normal individual. But in case of restrictive lung disease, we may not get up to 6 seconds also. Because prolonged effort may cause fatigue, and in patient with COPD may precipitate syncope and blackout. And now this is most important, the criteria which we have to look for. So these are once we do a spirometry, we have to look for 2 things. The repeatability and reliability, and number 2, we have to look for the curve, if the curve is satisfactory enough or not. First we come on to the indexes or the values. So the start should be explosive with a break extrapolation volume less than 150 ml. I will show later on how to look for this. The maneuver was performed with maximal inspiration and expiration. There was no glottic closure, there was no cough in between. And for FEV1 and FVC, between the 3 curves, the 2 base values should be taken within 5% or 150 ml of each other, whichever is greater. And the best FEV1 and FVC can be taken from 3 different maneuvers. So we will select 3 curves, satisfactory curves, and from there we will take the value of FEV1 and FVC. And if these 3 curves, the value should not vary from more than 5% or 150 ml. So this is how a acceptable loop looks like. Light. Light. So this is spirometry in a normal individual. So first tendency, even before interpreting the values, should be to look after all these curves. Because if we, in a normal individual also, if a patient do a spirometry like this, it will give an erroneous result. So this is not a disease lung, but instead the patient was unable to perform. So ideally, the inspiratory, there is a sharp rise and rapid rise, smooth gradual fall is touching the baseline, and this is the inspiratory loop. So it's triangular in shape in a normal individual. So what happens if the patient is providing a sub-maximal effort? Here what we can see is the peak is not attained. So if we look at the values, then what we see, there will reduce in FEV1 and FVC, which points towards restriction, but ideally this is a normal because it doesn't look like a curve from a restrictive lung disease. If the patient coughs in between, again it will give a erroneous result. So these are all sub-maximal inspiration and sometimes in tongue occlusion. So this may give a erroneous result that the patient may be having some form of extrathoracic airway obstruction. So these are the various spirometric indices. We all know what are FVC, FEV1. So these are the three most commonly used are FEV1, FVC, and the ratio of FEV1 by FVC. So once we have looked at the curve, we have found a satisfactory curve. Now we will look at the value of FEV1 by FVC. If it is lower than the lower level of normal, or we take it the values as 70%, then it goes in favor of obstruction. Then we look at the value of FVC. Once obstruction is confirmed, we look at the value of FVC. If FVC is normal, that means it's a pure airway obstruction. But if the FVC is decreased, that means along with airway obstruction, we have air trapping also, most commonly seen in COPD. Now, if the FEV1 by FVC ratio is normal, that means it doesn't goes in favor of obstruction. But two things can happen. Either it can be a normal spirometry, or the patient may be having some form of restrictive or interstitial lung disease. So again, we look at the FVC. If the FVC is normal, it goes in favor of a normal spirometry. If FVC is reduced, it goes in favor of restrictive lung disease. Now, this patient should be subjected to a complete PFT, or we call it as, mainly we look for TLC and DLCO. So these are the group of patients where we go for TLC and DLCO. So I was discussing about the curve. So before, once we have know how to interpret the values, now this is a normal individual with a normal spirometry, sharp rise, smooth fall, and everything is falling. It's a triangular in shape. All the indices are normal. So this is a normal spirometry. Now this is airway obstruction. So the typical finding which we see in obstruction, if we look at the expiratory phase, there is a concavity or scooping. We call it this one as scooping. It's not a smooth fall like this. Instead, it is prolonged. It's because of the low airflow, and it goes in favor of airway obstruction. Even without looking at the value, we can say this is a obstructive pattern. What happened in restrictive pattern? There is rapid rise, rapid fall, and the volumes are low. If you can see here, the area under the curve is very large, but here the area under the curve is very low. So there is a rapid rise, rapid fall. So this goes in favor of restrictive lung disease. Again, we can also know about if there is any variable airflow obstruction by either intrathoracic or extrathoracic, or if there is any fixed airway obstruction. So in extrathoracic obstruction, what we see flattening of the inspiratory phase. Whereas in variable intrathoracic, we see flattening of the extrathoracic phase. And lastly, this is a fixed airway obstruction commonly seen with tracheal stenosis or laryngeal stenosis. So there is flattening of both the inspiratory as well as the expiratory phase. We will not discuss about the causes, they are common. So few cases we can discuss. So now we have a 25-year-old male who have come, was selected as a fireman, underwent medical examination, no history of smoking, no history of any respiratory illness, everything was normal on general examination, X-ray was normal, and spirometry was done. So this is the spirometry. So what is the interpretation of this spirometry? If any student PGT can tell. No respiratory symptoms, no risk factors, just for pre-admission evaluation for certain job. So we can see the curve appears normal. It's very well performed spirometry, rapid rise, smooth fall. Now the curve appears normal, triangular in shape. And if you look at the values, the ratio is normal and both FE1 and FEC are normal. So this is a normal spirometry. Now second case, we have a 24-year-old male who presented with history of breathing difficulty, cough, chest tightness, mainly during seasonal change, associated with wheezing, no history of smoking. Examination revealed prolonged expression with rhonchi, and hemogram revealed eosinophilia and mildly elevated IgE. Other things were within normal limit, and the spirometry was performed in this patient. Can someone from the students can comment what we are getting in the spirometry loop? Thank you. It's an obstructive. You can see the respiration is okay, but there is concavity in the later part, scooping. And now we have done one pre-bronchodilator and one post-bronchodilator. So, and we can see there is a difference between pre-bronchodilator and post-bronchodilator. That means the patient has some response to bronchodilator. Now we can come on to this one. So pre-bronchodilator, if you see, the ratio was 68%. That means it goes in favor of airway obstruction. Now we look at the value of FEV1 and FVC. If you see, the percentage change is 25% in FVC and 30% in FEV1. And even this ml also is almost 800 ml in FVC and almost 600 ml in FEV1. So that means there is an airway obstruction with significant bronchodilator response. And when we call it as significant, once if the change in post-bronchodilator value between FEV1 or FVC is more than 12% and 200 ml. So both should be present, 12% and 200 ml. Then we call it as significant response to bronchodilator, more commonly seen in bronchial asthma. So now we can make a diagnosis of bronchial asthma, not only based on spirometry, because our clinical history is also important. So based on history and spirometry examination, now we can label him as a case of bronchial asthma. Similarly, we have a 60-year-old male presenting with gradual onset dyspnea associated with wheezing. He is a hypertensive and history of significant smoking is there. Chest X-ray was done. We can see this hyperinflated lung fields are there. And now spirometry was done. So any comment on this spirometry? The ratio. So from the curve we can see this obstruction is definitely present, because if we can see gross scooping is there. So that means significant airway obstruction is present. Now we look at the value. So FE1 by FVC ratio is reduced, and now we look at the value of FE1 and FVC. They are definitely changed. But now we are getting significant reversibility in case of FVC. Now what will be our diagnosis in this case? Reversibility we are getting, but in case of FVC, not FEV1. No, not exactly overlap. It's a COPD only. But in COPD also we can get reversibility. It's not like asthma only we will get. In COPD also we will get. But this reversibility is not seen in FEV1. It's mainly in the FVC. It's mainly because of the air trapping. So once we give bronchodilator, some degree of airway trapping is released and this patient responds. That's why this patient responds to bronchodilator, because if there is no improvement in lung function, there is no use of any treatment. So this patient lung function improved definitely, but not to a certain extent where we call it as reversible. But sometimes FVC may increase, and this signifies air trapping is present. Commonly seen in COPD. So that's why the diagnosis is COPD based on history as well as spirometry. So everything we have to cope up. Only test is not useful in diagnosing any form of disease. So we have to look in the background, history and clinical features also. This last case I can discuss. Now we have a 25-year-old male presenting with history of dyspnea and wheezing, non-smoker, history of road traffic accident 2 years back, required tracheostomy, was decannulated. Now this patient presenting with breathing difficulty was started on combination of inhaled steroid and LABA. Stridor was heard over the trachea on normal, and rest of the chest examination was normal. Chest X-ray was again normal. and he underwent a spirometry at an office, and this was the spirometry value. What is our inference from this one? So the ratio of FEV1 by FEC is reduced 55%. It goes in favor of obstruction. Now FEV1 72%, FEC is normal, so it goes in favor of. So diagnosis asthma. But the thing which was lacking here is we did not have any loop. The flow volume loop was not given. So this patient was again advised a flow volume loop, a complete spirometry again. And now, can we comment on this one? Though obstruction is present, but if you can see, there is flattening of both expiratory as well as the inspiratory phase. That means we are dealing with something called fixed airway obstruction. Now in the background of road traffic accident followed by tracheostomy and patient having stridor, this goes in favor of tracheal stenosis. So this goes in favor of tracheal stenosis. So any patient presenting with wheeze should not always be labeled as bronchial asthma, one classical example. And that's why only reading the spirometry values is not enough. So we have to also go look for the flow volume curve also. One restrictive. Now we have this 73-year-old male patient, gradually progressive dyspnea, dry cough, history of smoking was there, and on auscultation we are getting Velcro crepes in the basal area. This X-ray was done. If we can interpret interlobular septal thickening with honeycombing predominantly in the peripheral region is present. And now the spirometry was done. Any interpretation? So sharp rise, sharp fall, and we can see the area under curve is decreased in the background of the classical finding of ILD or IPF. So this is restrictive disorder. So this alone is not sufficient to call it as restrictive. Now we have to go for measurement of TLCH, DLC also, which in this case was reduced to label him as a case of restrictive or interstitial lung disease. So in this patient, this was done, and TLC was 42%, and diffusion capacity was also reduced. So this goes in favor of restrictive lung disease. And lastly, a 44-year-old female presenting with gradually increasing dyspnea. There are no other complete systemic features were there, and she was a smoker. Chest X-ray revealed prominent pulmonary conus, ECG, P pulmonale, and lead to an AVF. And this spirometry was done. Any interpretation in this case? It looks more like a normal spirometry. This ratio is normal and everything is normal. So we are getting picture of pulmonary hypertension, prominent pulmonary conus, P pulmonale on ECG, and a normal spirometry. That means it may not be secondary to any lung disease. So this patient was further workup, everything, the complete CECT was done, which only showed a prominent or dilated pulmonary arterial trunk, and saturation was less than 92 or 92%. Now another test was performed, which so a TLC was 72% of predicted, again in the normal range only, but DLCO was severely reduced at 26%. So in lung function test, spirometry normal, complete PFT TLC normal, but only reduced DLCO in the background of pulmonary hypertension, no valvular heart disease. So this was a case of pulmonary arterial hypertension. So roughly I will sum up. So most important thing is avoid using computer interpretation, because the AI feature which is now booming up, still not much reliable once we are interpreting the spirometry. Always go for clinical data and other investigation. Just reporting spirometry, even if I am asked to report certain spirometry, I may not be confident enough to label him as obstruction or mixed disorder without taking up the proper history. Examine the PFT data for quality control by looking at the curve, whether they are meeting the criteria, whether the appropriate 3 maneuvers, minimum 3 maneuvers were done or not. And we have to carry out comparisons, and we should have our own standard data for the respective population, because since the lung values varies with age, sex, as well as the gender, as well as the ethnicity, so ideally we should have our own data. And this patient may require further testing if we are suspecting another form. For example, in one case we were suspecting ILD, in another case we were suspecting pulmonary arterial hypertension. So this patient should be subjected to further tests for evaluation. Okay, thank you. Sir, Jugesh Sharma sir have few cases which since we have time we can discuss.
So somebody has told in WhatsApp that today is the Zoran and tomorrow is the marriage ceremony. But Zoran is very nice. So I congratulate again the party of Tezpur. But there is one thing, when I first started the postgraduate in pulmonary medicine, there was 3S in the medical college. 3S means Jugesh, Suresh and Kripesh. And where 3S is there, usually Sharma, there is some always problem. So today is also there is some problem because we will be unable to complete within the limited time. We will take again extra 10 minutes. So whatever it is, spirometry was discovered by Hutchison, who was a surgeon in 1840. But till today, in even medical college, there was not a spirometry machine properly. Sometimes it is done by the company people, but it is available in the private, but done by not by the trained person. That is our head. So this is important. This will remain as our physiology actually. So we will not go in details. That is very important for pulmonary function test. Already it is discussed. We will discuss some abnormal pattern of peaks. First, if we see in this graph, there is a blunt peak. If you get this type of spirometry, but result you will get in computer machine. Then, if there is blunt peak, you will get a result. But if there is a blunt peak, then you should repeat the test. Secondly, Suresh is already telling about the notes. So indicates a cough or hesitate to start. Because machine to iman jorot fukawa na, mana birat mana fukawa lage. Moi noaru asolta throat. Buji paise. Gotike there was hesitation. Gotike jodi first part of the cough, then it is not accepted. But if it is in the sloping part, if there is cough, then it is accepted. It is not accepted, then we will ask to again do the test, repeat the test. Then delayed peak, already discussed this. Flat peak, reduced flow rate along with the expiratory plateau indicates intrathoracic obstruction. That is already discussed. If you remember this graph, then you will be able to diagnose. But history is important always. Then the steep curves. Steep curves means sudden up, sudden down. Already discussed. Always you will get in restrictive lung disease. One example is the interstitial lung disease. This is the rat tail appearance. If you see, you will get this type of appearance. It is always you will get in obstructive type of lung diseases. Then notches on slope. If there is problem on sloping, then it is an acceptable graph. But if there is undulation on the descending slope due to cough, does not affect the result. But in proximal part, jodi utrahamat hoy, there is cough, then you should repeat the test. Then abrupt termination. When patients stop expiration before complete relaxation, test to be reported. It is commonly seen in children. Fixed airway, upper airway, they call already. Small airway, large airway. If the size of airway is less than 2 millimeter, then it is small airway. More than 2, large airway. Our maximum resistance 80% occurs in the large airways. Small airways, 20%. For that reason, most of the region remains silent actually. So, this slide is very, very important. If you remember that slide, then you will be able to interpret the pulmonary function test very easy. Then, first you see the FE1 and FBC ratio. If FE1 and FBC ratio is normal, see the FBC. If FBC is normal, spirometry is normal. Then this patient is a normal study. But if FBC is low, then it is a restrictive lung disease. So very easy to exclude restrictive lung disease. How? FE1, FEV1 and FBC is normal, FBC low, restrictive lung disease. FEV1, FBC is this time low, not normal, low, obstructive lung disease. So in obstructive lung disease, then you again see the FBC, forced vital capacity. That may be normal or low. If it is normal, your diagnosis is pure obstructive lung disease. Pure obstructive lung disease is two. One is bronchial asthma, one is COPD. Then you do the reversibility test with beta-2 agonist. If there is reversibility is there, good. Already previous speaker has told, then it is a bronchial asthma. But not proper, then it is a chronic obstructive airway disease. Clear? FEV1, FBC ratio is low, obstructive. FBC is normal, pure obstructive airway disease. Maybe asthma, maybe COPD. Give bronchodilator like salbutamol inhaler. After 15 minutes, repeat the test. If there is good reversibility asthma, otherwise it is COPD. Then FBC is low. Problem will come. Two things. One may be obstructive airway disease, or it may be a mixed disease. So how will we differentiate this obstructive and mixed disease? Then we should do some additional tests. That is the total lung capacity. If total lung capacity is normal, then this is a pure obstructive disease, and if it is low, it is a mixed pattern. But TLC term is spirometry we cannot do properly. I report to napao. Ekon slide খুব important. Ekon sale ar gote. Jodi ami just slide khon monot se sobore FEV1 FBC is normal, FBC low, restrictive. FEV1 FBC is low, obstructive. FEV1 FBC ratio is low and FBC is normal. Ki asile? Chronic. Pure obstructive airway disease. Ekhini monot rakhibo lagibo. Low, mixed, or maybe pure obstructive airway disease. Eta prothom case to. In always, যিখন আমি তেওঁৰ প্ৰেডিক্টেড ভেলু লওঁ সেইখন হ'ল মানে এজ ছেক্স তাৰ ওপৰত সদায় থাকে এণ্ড হাইট গতিকে সেইকাৰণে স্পাইৰোমেট্ৰি when you will do that these three is important age gender and at the same time the height এই তিনিটা চাব লাগিব that this patient is having FBC is 65% observe poor effort but after that that patient is having good effort 82% ভালকৈ কওঁতে 82% আহিলে FEV1 is 59, but with good effort it was 70. But if you see the FEV1 FBC ratio is 88%, with good effort 83%. 88% means FEV1 FBC is normal or low or high. It is absolutely normal. And if you see now, the FBC is 82%, FEV1 is 70%. That means FBC is normal. So in that case, it indicates that that person is having a lung function is within normal limit. Kintu agor khanit jeta pore effort hoise report to kintu beleg ahibo. For that reason, that is important. Koi gol ekhon? Next case. এবার দেখা পাইছো FEV1 FBC is 69%. That means it is low, reduced. And if we see FEV1 is 66% and FBC is 83%. So what will be the diagnosis now? FEV1 FBC is 69%. তার মানে কি ওর ফলে গল? Obstruction. Yete kono bhai kuche. obstruction. গতিকে এইটো কেছত obstructive airway disease আহিলে বুজি পাইছে একদম সিম্পল এটা বস্তু চাই আমি কৈ দিব পাৰিম নেক্সট কেছটোত চাওঁ আমি FEV1 FVC ratio is 40% কিহৰ ফালে গ'ল obstruction whereas FVC is 63% এবাৰ কিহত যাব যদি FVC pure obstructionৰ ফালে গুচি গৈছে গতিকে দিছ পেচেণ্ট ইয়াত আৰু বেলেগ আছে সিমানখিনি জানিব নালাগে আমি পিউৰলি দিছ ইজ এ পিউৰ obstruction next case if we see FE1 FVC ratio is 51% or a photo but there that next is FVC is 85 কি থাকিলে নরমাল থাকিলে আর এবেগে এটু থাকিলে FEV1 is also 51% low. So what is your diagnosis? After post-bronchodilator, the Betrozone's pre-bronchodilator 55 and 55, FVC and FEV1. Kintu yare pasar to improve hoise. Je ki hoba pare etu? Tane reversibility to hoise. Reversibility to hole ki hoba? Pure obstruction with significant reversibility. That means that is a case of bronchial asthma. Now, again, if you see in that state, FEV1, FVC is the pre-observed is 44%, later it become only 47%. That means it is low. Low means obstruction. Is it? Next, you see the FVC. FVC is also low. So when FVC is low, যদি নর্মাল হলো পিওর অবস্ট্রাকশন হলো সিন্স FVC is low it is a mixed pattern so in that case we will see that severe obstruction with reduced vital capability কারণ কি FVC যদি লো থাকে দুটা হব পারে mixed pattern or obstructive airway disease we should see that TLC is normal then it is pure obstruction and if TLC is low then it is a restrictive আমি বাকি TLC ফলে বেশি না যাও যেটা আমি ডিসকাশন হোৱা নাই এটাৰ ওপৰত in that graph if you see FEV1 FVC ratio is that is 87% and if we see FEV1 is 40% FVC is 40% what will be your diagnosis now okay yes restrictive pure restrictive lung function গতিকে ইমানকা কেইটা কেছতে ছটা কেছতে সব ক্লিয়ার হয়ে গৈছে আলটিমেটলি so we will continue for case number 7 or not because now if you see again FEV1 FVC ratio is observed predicted was 78% tane graph to jito ahe to ready made but software pa aibo but we have got 40% tane low paiso now come to the FVC is 63% and FEV1 is also low. So especially FVC is low, FEV1, FVC is low. What is your diagnosis? Huh? Yes. Obstructive. Hey, kintu jetu etu ase ami mix to doibo paro. Kintu yat thik teneko ku clear cut noy. Yar lagad aru ketaman kotha ase je himan hole na jao aru. That is a obstructive lung function with non-communicating. Ki karonot আমি এটোৰ ক্ষেত্ৰত আসলতে TLC কৰিব লাগে বডি প্লাজিসমোগ্ৰাফি কৰিব লাগে দ্যাটস বডি প্লাজিসমোগ্ৰাফি is not available in Assam till now so many times I wrote when I was the head of the department to government but till now we are not getting a body প্লাজিসমোগ্ৰাফি do we have a postgraduate department আৰু এটো প্ৰাইভেট বিলাকো কিনিব নোৱাৰে কিয় যিমান পইচা খৰচ হ'ব হেমতে তেওঁলোকৰ লাভ নহয় আসলতে benefit so that part is also important now again we come to a FEV1 FVC ratio 81%. That means it is normal. If we see FVC is 87%, FEV1 is 84%. What is your diagnosis? এবার সব নরমাল দেখা পাওয়া গেছে no evidence of obstruction or restriction তানে এটো নরমাল গ্রাফ আছিল আগৰটো এইটো ক্লিয়াৰ নে এইটো Any confusion? Postgraduate? Next again, FEV1, FBC is 56%, then reduced. Reduced hole kon phale jabo? Towards obstruction. It actually says FBC is high, FEV1 is also high, FBC is very high. And if you see in the inspiratory loop, that is flattening, that flat hobo nalage. Jodi flat hoy tetya gom pabo there is obstruction. Gotike obstruction to ko hobo lagibo. There will be a variable extrathoracic obstruction. Already second slide dekhoisile. Moi kane beshi discuss kora nai. Tane extrathoracic obstruction ase egestot. Jodi dekha pai je inspiratory loop to jodi flattening hoy. Ebar dekhabo upper part of the flattening, lower part of the flattening. Dekha paise ne bostu to? FEV1, FBC is 84%. Normal, but whereas FBC, FEV1 both are high. Aru jodi ami graph to sao, eto normal graph na hoy. Upororo apni dekha pabo flattening, toloto flattening ase. Tar mane in that cases, what happens? That person is having fixed obstruction. Agotor is variable. Already, the West speaker has told it nicely. Kya hoy? Ami himan bakhya korar somoy asolte nai নহলে koi golo hoy ultimately. In that curve, if you see again, FEV1, FBC is 62%. Whereas, previously it was observed 68% and next time it was 64%. And another was this FEV1 was 50%, but later it became 49% low. But FE1, FBC is low. And if you see the graph is also not proper. So what is this? There is flattening of the extrathoracic part. Extrathoracic part means upper part is expiratory, and lower part is inspiratory. The expiratory is the loop to side, that flattening is. That means there is obstruction. That is, you will get this type of inspiratory expiratory part. That is interthoracic, lower part of pale. Taramane inspiratory loop to the pi eto extrathoracic, or dota pale fixed. Eto ki abo diagnosis graph to sai kagetia. Ebar ase ki expiratory phase to flat hoy ase. Tane ki hobo? Extrathoracic hobo na intrathoracic hobo? Expiratory question hoy upor dhole intrathoracic, tala dhole extrathoracic. Simply monot rakha karo. Beshi mane bhabile aru bilak monot na thake tar mane. Kintu first slide kon hoday monot rakhbo. FEV1, FBC tar jot sai jabo. It will be very easy. And in that case, Kiki Vale, FEV1, FBC is 69%. After, before bronchodilator, it was 65% FEBC and FEV1 was 59%. Into bronchodilator, it had become 84% and 59%. So what will be your interpretation now? Allah ekon dekhabo je gute effort to kintu bhal na hoy. Expiratory jeto flow eto agote শেষ হয়ে গেছে. So that is a pure obstruction with ill-sustained effort, mimicking restrictive pattern. Any runner pray baba ekane last of condition. Gotike I think apnalokor etu gote complete. So Zoran is very nice. So tomorrow marriage ceremony will be again very beautiful. And last day, konobai likise je na koina mai hobo noy khorat jabo. But on that day, so there should not be any weeping because they are managing so nicely that nobody can forget this event actually. So on that day, there should not be any weeping. This is my request to all of you. And if there is any question to our speakers are there to answer regarding NIV and spirometry. So they are ready to give. But it is not possible to cover an workshop within 1 hour. That is also impossible. And that impossible is happening for us because 3 Sharma is there and 3 S is there. 3 Pesh, Suresh and Jugesh. So that is always happening. Thank you.
Thank you, sir, for a wonderful presentation. Thank you, Suresh. Thank you, Kripesh. So, Suresh, I just want to ask you one thing. Like we have talked about the spirometry, so we have getting lots of cases of connective tissue disease, like sclerosis, which we get. So how, in those cases, how do they go for the spirometry? Because it's very difficult to hold up the breath.
So these are the ideal candidates who should go for not only spirometry but bloody plethysmography also, because most of the connective tissue disorder involve lung, and most common finding we get a interstitial lung disease. So definitely we are going to get a restrictive pattern. So in that case, we should not ask them to expire for at least 6 seconds. Sometimes up to 3 seconds, the maximum they can blow. So only thing we have to look at the curve if it is touching the baseline. The moment it touches the baseline, that means this is the maximum the patient can. And ideally we should get a restrictive pattern, and we should be confirmed by doing a TLC as well as the DLCO. And we can quantify the severity also by looking at the value of FVC or TLC. If more than 70% is mild, if between 50 to 70 is moderate, 35 to 50 severe, and anything less than 35 very severe. Same with DLCO. So they have a prognostic implication. And once we start treatment, again we can follow up this patient. If the deterioration in the lung function over 6 months in FVC or DLCO is less than 5%, that means the patient is responding. If it is more than 5 to 10%, that means the patient is deteriorating.
This thing also goes for children. For children also, children also 3 seconds.
Apart from this, sometimes doing a spirometry also technically sometimes difficult. So nowadays things like impulse oscillometry has also evolved. So in impulse oscillometry, this is just like doing a spirometry, but patient has to just do their tidal breathing, and there is a ultrasound wave from 5 to 20 hertz is passed through a ultrasound processor, and that will airway will reflect from the airway and lung parenchyma. From that also we can know that obstruction or restriction pattern is there. So this is particularly useful for children, and yes, for adult also who cannot. And apart from that, the diffusion capacity, as you have asked, can also helpful in if you suspect restrictive disorder or if a patient has underlying CTD.
So actually in pulmonary function test, we do one is gas diffusion test. But in gas diffusion test, we will do the DLCO, we will do ABG, then we will do the capnography, oscillometry, then even the pulse oximetry. That will also give an idea. But on the other hand, there will be mechanical testing, that is spirometry. We could do the dynamic and static. Dynamic. But there are some questions from my side. In pregnancy, it is indicated or contraindicated first?
It's a relative contraindication.
So in 3rd trimester, it is contraindicated. But always physician to take the decision at the time of the spirometry. Now my question is to all now. Suppose a female case came to your chambers. She is 36 years. She had a previous history of abortion. Now she is conceived for 2nd time. She is having bronchial asthma. But nowadays, we are telling, but our guideline is also telling that spirometry is such a machine, like for seeing the temperature, thermometer is necessary. Like that, for see the blood pressure, sphygmomanometer is necessary. And spirometry is also important like that for assessment of the severity. Accordingly, we treat by according to the GINA guideline or GOLD guideline, asthma COPD. So in that case, patient is having asthma, whether he will do the spirometry or not. There is nothing written in any book. Now what will be our decision in that case?
So for diagnosis of bronchial asthma is predominantly a clinical diagnosis. Even with a normal spirometry, we can a patient may be having. So we should start the treatment and we can defer the spirometry.
Why
because it's not adding anything to your diagnosis, number one, neither to the prognosis or the treatment which we will give to the patient. Only the risk of complication is high.
Stage 1, then I will give only steroid. But if it is 2, I will give.
It's all from the history it will be enough. So from history and examination it will be enough, I think.
Yes, we will not do. Especially for that person is having 3 abortion previously. Again now 36 years old she is. If we do spirometry on that day, if there is bleeding, every blame will give to you. And next day the party will come to you that is happening only for you. Because spirometry sobbe ekbar koi post gadget kani expose hobo. Kani koi spirometry kore. Tone khub jurat phukabo lage asolote. So we should see this part also.
Why 36 years old? Why you
অলপ বেছি বয়সটো বঢ়াই দিছোঁ যাতে নকৰে বুলি কয় ইউ কেন টেল ইট ইজ 20 মানে আমাৰ বিয়াৰ কিমানলৈ ৰেষ্ট্ৰিকশ্যন আছে আপ টু 18 ইয়াৰ্ছ ন ইউ কেন টেল 22 অলছ' ইফ দেৰ ইজ টিটেন এবৰ্চন আই উইল নট ডু 38টো দিছোঁ যাতে আৰু অলপ বয়স হয় যাতে নেক্সট ইছ্যুটো আৰু চান্স নাই সেইকাৰণে কৈছোঁ
So, Dr. Kripesh, I think I want to ask about the home NIV. Any comments about home NIV?
Home NIV or home BiPAP, we basically prescribe for that evidence for basically two type of disease. One is your severe COPD patient who has recurrent type 2 respiratory failure and require at least 2 to 3 times of hospitalization because of acute type 2 respiratory failure. So these are the group of patients who are benefit. And second group of patient is neuromuscular disease patient where the respiratory muscles are involved, where the home NIV works wonderful.
Yes, I have a question to the speakers. So ideally the spirometry should be done in sitting or standing posture. And if it's sitting, in which condition is like?
Ideally, it should be done in a sitting position, sir. Not in lying down, because definitely the lung function will decline because of the movement of the diaphragm upwards. Sitting or standing, sitting definitely, because it's a forceful expiratory maneuver. And every chances are there, patient may end up sometimes in vasovagal attack, and he may fall and may get injured. So sitting position comfortably without any tight clothing, no dentures, then this is ideal condition.
Rest should be also very relaxed. Relaxed. 5 rest taka jodi noy restrictive pata nai upukaba noy no etu maribo lagila noy bote
And one thing is that the patient is not cooperative all the time because they don't give their full effort. So it is very difficult because as spirometry when you do, suppose you have said that at least 8 readings of FBC to be taken.
3 minimum readings, up to 8 we can go.
Yeah.
So if the effort is not good enough, then what will happen? If we directly look at the values, it will give a typical picture of restrictive lung disease. Both the FVC are reduced, FE1 is reduced, but the ratio is normal. But in ideal condition, what is happening? If you look at the loop, it's a sub. So that's why loops sometimes also become very important. If you look at the flow volume loop, if it is normal, we can say, okay, the spirometry loop appears normal. However, the patient has not performed the test according to the ATS, ETS criteria at the submaximal level.
No, I have seen that whenever you do that test, you don't get the typical that flow chart.
It's all about this test is dependent on 4 criteria. First, machine. So machine will never give you a correct interpretation. Number 2, patient. The full cooperation and effort of patient is required.
Yes.
Third, technician. The most important part is the technician. If we don't have a trained technician to demonstrate it properly, then definitely we will get. Look, in our clinic also we are doing spirometry 2 out of 10. We are getting 3 or 4 spirometry good enough. But where I was doing my post-graduation, we have definitely 4 or 5 trained technicians. Almost 100% of the spirometries were according to the criteria. So it was all dependent because we cannot go and teach the patient each and every time to do a spirometry.
Yes, it's very time consuming also.
It's very time consuming, but if the technician is trained enough, the spirometry will hardly take 10 minutes.
Hello, good evening. What is the ideal time or situation of the patient to do spirometry, whether in acute stage or asymptomatic?
So in acute stage, if you ask the patient to do, patient is already breathless. Definitely he won't be able to go for a test properly. Every chance is there that we won't get the criteria which is required. So better we treat the patient, make him stable, and then we do a spirometry. In any acute phase, definitely we will get a deterioration of the lung function up and above the baseline. So to call it as a level, as a case of moderate COPD, mild COPDs, so it should be done in a stable time. Then only we will get an idea what is the status. In acute exacerbation, definitely lung function will deteriorate.
So suppose patient comes with a bit severe stage or acute stage, then how we formulate the treatment part if we don't get the exact diagnosis?
Management of, if we are talking on the line of COPD, so COPD per se, management has 2 different plans. Management of stable COPD is a different issue, and management of acute exacerbation. So in acute exacerbation, we are not dealing with mild, moderate, severity. We are treating on the basis of acute exacerbation. We have to give antibiotics, bronchodilators, steroid. We have to look for saturation. If it is low, we have to give oxygen, NIV with or without invasive mechanical ventilation. This is the plan for acute exacerbation. Once the patient settles down, he is planned for discharge, then we do a spirometry, and now we assess the lung function. If required, we can repeat after 3 weeks also to
to change, and then we can label it as mild, moderate, severe airway obstruction.
That time, if necessary, you can do ABG.
Because
pulse
the
oximetry, ABG is also not there. Pulse oximetry will give us
because the goal guideline clearly has differentiated between the management of stable COPD and management of acute exacerbation of COPD. Similar with asthma also. In stable phase, we treat differently. At the time of exacerbation, definitely we treat it differently.
Last question from me. When you do a reversibility test, what medication do you prefer? Whether you prefer ACS or you prefer a long-acting bronchodilator?
So which one?
For
reversibility, okay.
Reversibility.
It's a short-acting beta-2 agonist. A salbutamol is preferred, sir. 200 micrograms.
No steroid?
Huh?
No
No steroid, sir. Steroid was used previously at one point of time. There was a term called steroid-resistant asthma. I think even sir might have got at that time. So the patient who don't used to respond to steroid, they used to see whether it's a steroid-resistant. So they used to give prednisolone 30 milligrams 7 to 10 days. On the start they do a spirometry. At the end of 10 days they used to do a spirometry, and they used to see the response. If it was less than 12% or 200 ml, that means patient was labeled as steroid-resistant asthma. But now this
during post-COVID time, many people use NIV in their house also. So there is no question for NIV.
I have a question for Kripesh. How significant is the ROX index or the HECO score for the NIV, and which one is better, NIV or the HFNC in the treatment of COPD, acute COPD? And how significant is the HECO score or the ROX index in the day-to-day practice in the ICUs?
We do not use those scores in day-to-day clinical practice, and particularly for treating COPD, NIV is always better compared to HFNC.
What is the reason behind?
Yes, definitely, because majority of the patient with COPD exacerbation usually have a type 2 respiratory failure, and HFNC actually give a little bit of positive pressure in the tune of around 5 centimeter water pressure, which is not adequate enough to give a proper ventilation of the lung. HFNC is very good giving oxygenation of the lung, but this is not good in providing ventilation of the lung. So if the patient has a type 1 respiratory failure, like your milder form of ARDS, where HFNC works wonderful. But if you have a type 2 respiratory failure like that of a COPD, that BiPAP will work better.
So the benefit of NIV goes beyond oxygenation. It reduces the work of breathing, increases the transabdominal pressures. Even we can deliver drugs, nebulization through NIV. So it's beyond oxygenation. It helps in washing out carbon dioxide, which is not possible with HFNC is only for oxygenation, if you can say in roughly. If you oxygenate properly, then only it will decrease the work of breathing. But by giving a positive pressure, we are de-stressing the respiratory muscles which are going into fatigue. Also, because of IPAP and EPAP, the carbon dioxide wash out is fast, and NIV can also be used as a tool for delivering the. And
one more of disadvantage of HFNC in COPD is that you are giving a high flow oxygen. That will again reduce your respiratory drive. So patient will likely to have more carbon dioxide retention.
Sir, what should we look for surgical fitness? For surgical fitness, what should we look? Yes.
This is something dicey actually.
For
this
maximally for COPD, stable COPD patients.
Once spirometry for surgical clearance, extrathoracic surgery and extrathoracic surgery. Definitive role in thoracic surgery. Once we are going for lung resection, then spirometry is a must. There is a formula called post-operative predictive FEV1, which we calculate as FEV1, which we have got in spirometry, multiplied by number of segment which will be remained after surgery, divided by 18, which is a total segment. If it is less than 800 ml, patient is not fit for thoracic surgery. Now for extrathoracic surgery, abdominal surgery, clinical evaluation with other tests is found more useful than spirometry, because spirometry per se, not even FEV1 is not an indicator which patient will end up in postoperative pulmonary complication, number one. Few studies have shown that FEV1 less than 70% has shown higher incidence of preoperative pulmonary complication. But these patients were COPD. Irrespective of their lung function, COPD patients are more predisposed, so there is no consensus. Recent few studies have shown that if instead of taking FEV1, if we take FVC, few studies have shown that a decrease in low level of FVC is definitely associated with higher risk of postoperative pulmonary complication. But which group of patient, what should be the cutoff value is not demarcated till now. So spirometry alone should not be any, in fact, even a bed spirometry is not a contraindication for any surgery. Clinical status and proper, the only advantage is if we do a spirometry, we get an idea about the lung function, we get an idea about the disease. If the patient is in acute exacerbation, treat it first. Make the patient comfortable, treat him to his best pulmonary condition, then only go for surgery.
If patient is clinically stable, then we don't need spirometry.
It's ideally not much of help, but still we are doing it. Even many people, even we are doing it, so that we can get an idea about the status of COPD. The more the COPD is severe enough, the more the chances of postoperative pulmonary complication. And the most common postoperative pulmonary complication is not this one, type 2 failure. It's mainly because of basal atelectasis we get a type 1 failure, or it's because of postoperative pulmonary infection, which is more common in COPD, irrespective of the stage.
Thank you, sir.
So one question, a practical question. These CLD patients with ascites, with varices, we usually give them beta blockers. After some time, after putting the patient on beta blocker, the patient comes back saying that I'm having respiratory problem. When you auscultate, there is no bronchi. But the patient has ascites. Will spirometry be beneficial in this group of patients with ascites?
So the only thing in spirometry which we'll get, the loop we will get a normal, but the values of FEV1 and FVC will be decreased because the diaphragm has been pushed up. That's why the patient won't be able to perform the spirometry at its best level. So though the values will be of restrictive pattern, but the loop will be normal. So it's mainly because the moment we do ascitic tapping, again, if the patient is asked to do a spirometry, it will come back to the normal values.
Then when will we treat? Because I want to, whether I should continue with the beta blocker. I will not continue the beta blocker.
We should continue with the beta blocker. If there is no history of asthma, no beta blockers are not contraindicated. Even if
no history of asthma, but you get patients, no history of asthma, put on beta blocker, then he comes with respiratory, you see no other features. So probably he is having a bronchospasm.
Sir, there are two things maybe. If the ascites is not so much significant, we have to think that patient may have a beta blocker induced bronchospasm. If the patient has significant ascites, I think tapping of ascites fluid may give him relief of his dyspnea. So if the ascites is not so much, clinically not so significant, but after the beta blocker patient is developing dyspnea, definitely this patient need to be evaluated for a obstructive airway disease.
Is it better in these patients to do give him a beta agonist and then see the response?
Sir,
yes, if the response is there, then we can probably...
Sir, ideally in this condition, the test which is indicated is a bronchoprovocation test. What we do, the patient is asked to inhale methacholine, do a spirometry beforehand, and the spirometry is done after inhalation of beta to methacholine. If the fall in FEV1 or FVC is more than 20%, that means airway inflammation which was present, which was not clinically significant, but because of inhalation of methacholine, the inflammation has caused bronchospasm significant enough. We call it as PC20. So it should be the dose. At that dose, if it is causing the fall in FEV1 by more than 200 ml or 12%, that means it is the airway is hyperreactive.
Practically we cannot. Can we give just bronchodilator and see, okay, the improvement?
Now, we have to give bronchodilator and see.
One thing is that regarding this type of things, we can discuss many things. But important thing is with the patient, whether if beta blocker is essential for portal hypertension, which is more important, then we will continue. We should see whether asthma is that important or beta blocker is important. If we stop the beta blocker, is there any problem? If no, I will stop beta blocker for the time being. We will
clear this part. If there is severe ascites, as Dr. Kipasandan Sharma is telling, we will drain this. And if mild, then we will see that part. We will stop beta blocker for the timing, then again we will give. And that decision will be taken by the gastroenterologist like you, regarding portal hypertension. If you say we will continue, if you say, but otherwise we will, from our side we will tell just stop beta blocker. But gastroenterologist will tell no, beta blocker is important. Then we will continue the both. Yes.
We can continue both.
This is the only solution. Now my last question again. 86 years old, people again I am telling 86 years because patient is very old now. From a very poor background, no Ayushman card, admitted in hospital with respiratory failure. Acute exacerbation of COPD, severe respiratory failure type 2. Now patient is having throat secretion also. Now whether how I will manage this case, whether I will put ventilator, NIV. NIV is not indicated because patient is having throat secretion, etc. Regarding mechanical ventilation, it is again a debatable question to the house. Patient is very poor. In nursing home, if I put in mechanical ventilation, he will sell everything. And ultimately, patient will also, there is a big query. Now what is the suggestion of the house actually? It is not from us actually. Because that type of problem usually we face. No, Ayushman card nahi. Ekhane koise agote. Because we should discuss the practical thing here actually, than that of the theoretical thing more. And after that, there will be certainly some individual opinion I will not give. I will discuss with them or I will consult with their attendants regarding her. So house is certainly agreed with this. So if it is agreed, then we can stop this session. Because Sangit is given this message of Zoran and marriage ceremony. So Zoran is really very good.
During pregnancy, what are the safe bronchodilators, especially in the first trimester?
So inhaled bronchodilators, all are safe, sir. All are safe.
Another question, during cesarean
So per se, if the patient does not have any allergic reaction to anything, even spinal will do. So as such, the only thing during operation, mainly during GA, which we have to look for, if the patient has taken any form of systemic steroid in the last 6 months. If any patient has taken even a single course of prednisolone 30 mg 5 to 7 days, at the time of operation, because there may be adrenal suppression, you have to give 100 milligram of hydrocortisone just prior to surgery.
Yes. For precautionary measure, we can give the steroid 100 milligram hydrocortisone 15 minutes before surgery. Or during surgery, if there is spasm, then we can repeat the steroid at the same time nebulization. That is the. So I hope now we can conclude the session.
So we will conclude the session now. Thank you all.
I would like to thank the speakers, our moderators, and also our august audience for a highly interactive session. Before we disperse, I would like to call the moderators and the speakers back on stage to just capture a moment in a photograph. Can we please have... Ma'am. With this, we have come to the end of today's scientific program. We have a few cultural events lined up. Thereafter, we will start the dinner in the food court. Before we disperse, a few reminders for tomorrow. Breakfast will be served from 8 a.m. in the food court. There will be a flag hoisting ceremony at 8:45 a.m. in the morning. At 8:55 sharp, we will reassemble in this very hall to start the academic session for tomorrow, which will